Good morning, everyone. It is with great pleasure and honor I extend a warm welcome to all the esteemed guests, faculties, delegates, and dear students to these 2 days of National Workshop. Myself, Mrs. Fragancia Gibbelson, Assistant Professor, Department of Medical Surgical Nursing, feels privileged to host the National Workshop of these 2 days. MGM New Bombay College of Nursing is one of the pioneer institutes in India to offer MSc Nursing Nurse Practitioner in Critical Care program since 2017 and always looks forward to provide excellence in nursing education, patient care, and research. It takes pride in imparting value-based education where students are trained by renowned medical and nursing preceptors and prepare the students to render excellent patient care. This workshop serves as a platform for us to come together, exchange ideas, and explore solutions to the challenges that lie ahead in the field of nursing. As we embark on the day one of the national workshop, let us embrace diversity of thought, respect for one another, and a shared commitment to excellence. Throughout the national workshop, I encourage all of you to actively engage in discussions, share your expertise, and forge meaningful connections that will endure long after our national workshop. Once again, I express my happiness in hosting this national workshop and extend my heartfelt welcome to each and every one of you. I wish you all a nice learning experience in our campus and suggest you to make the most of this opportunity. So without much delay, let me introduce the first speaker of the day, Dr. Vernika Kala. She has completed her MD in emergency medicine. She is also an instructor of advanced trauma life support. Currently, she is working as an associate consultant at HN Reliance Hospital. We welcome you, ma'am. I request Ms. Vandana, Associate Professor, MGM New Bombay College of Nursing, to felicitate Dr. Vanika Kala.
Good morning, everybody. I'm Dr. Varnika. I've done my MD from here. I'm very happy, always very happy to come back to MGM. And I'm very happy to see some familiar faces in the audience. So without wasting any time, since we are very short in time, I want everybody of you to understand that this topic is basically the baseline for the next 2 days, today and tomorrow. If you don't get this topic right, it will be difficult for you to understand anything else. It's a very simple topic. Try to stay with me. Are you all up? Okay, great. Okay, so the topic is primary survey and adjuncts. Uh, I want this to be an interactive session. So can anybody tell me what's the primary survey? Come on, guys. Ujjao. Jignesh, what's primary survey? ABCD. So initial assessment. Initial assessment is primary survey. When you see the patient first, when the patient comes to you, first time when you examine this patient, that is your primary survey. So, okay. So before we go ahead and start analyzing the patient, there are two things that are very important. Number one, we are prepared for the patient. We should have everything ready. And number two, if there are 5 patients coming in together, we should know which patient to deal with first, which is called triage, sorting out the patient, right? So, how do you prepare for a trauma patient? How do you triage the trauma patient? What is A, B, C, D, E? Adjuncts of that. And if you want to shift this patient somewhere else or keep the patient in the hospital, this is all what will be covered in this class. And rest of it will be taken after me. So this is what I'll stop at. Okay, so starting with preparation. Can you just move this? So starting with preparation, suppose you get a phone call. You're all in the hospital, you're working and you get a phone call. There's a 20-year-old boy getting wheeled in with a head injury. So what will you do? Will you just sit, patient, no, you'll start preparing. So how do you prepare? Any trauma patient, you already know will require a crash trolley, will require a resuscitation bay, right? So you'll keep your resuscitation area cleared up. You'll get your crash trolley. Now you know that this patient is having a head injury. So what will you do? This patient with head injury, what will happen? Okay. This patient with head injury might have an airway issue. So you will keep your airway, intubation trolley, airway kit, everything ready. Along with that, you will make sure you have IV lines, crystalloid solutions. So once everything is prepared, you can now go ahead and also inform the other departments. Because when a trauma patient wheels in, there are many departments that get involved, not just the ER or the trauma department. So you have to inform the hematology department to keep the blood ready. You have to inform the radiology department to keep it cleared up so that if a patient requires an urgent CT scan. Okay, so this is how you prepare. Now tell me, suppose you don't get this phone call. On every shift, when you touch the ED surface, you have to prepare. You get a phone call, you're getting a patient, you're not getting a patient. The moment you enter your ED, the moment you enter your ICU, you have to start the preparation. So the first thing you will do is check your crash trolleys, check your intubation के लिए जितना भी आपका kit है, check your laryngoscopes, whether they're working or not, whether you have all the ETs that you need, whether you have all the medication, is the IV cannula kit ready with you? So readiness is the first step. Okay. Now coming to the next point, triaging. So you were on this phone, you were told there is a 20-year-old boy who is walking in. Instead of that 20-year-old boy, or with that 20-year-old boy, 3 more patients came. Now you have 4 patients together. Who to attend first? It's just you, another physician, and 1 nurse with you. What will you do? 3 of you, 1 nurse practitioner, 1 nurse and physician. Can 3 of you attend to all the 4 patients together? No. So now you have to make a priority list. Sorting out your patients is basically called triage. Understanding which patient will require you to get attended first is triage, right? So this boy is bleeding from his head. He's very drowsy, and the other 3 patients are walking in. So which patient becomes your priority? The first one. So understanding the priority is important. Now, just want to quickly touch upon the small point, which is called mass casualties. Sometimes what happens, instead of these 4 patients, 20 patients will come in together. Now, the hospital is not capable to handle 20 patients together. Then it will be called mass casualties. If 20 patients are also brought in together, or 50 patients are also brought in together, the method of triaging remains the same. You have to sort the patients out based on their airway, their breathing, and their circulation compromise. Obviously, you have an entire class on triage, so I'm not getting into the different systems of triage. But understands that even if you get a big chunk of patients coming in together, you need to triage. And what we used to do here is we used to, in MGM, when we received mass casualty, we used to give each patient tags. Category 1 patient will get a red tag. Category 2 patients will get a yellow tag. So this sorting of patients will help us understand which patient to go to next. Okay. Red is for most urgent need. Yellow is the patients who can wait for some time but need to get treated because they might get converted into red. Green are the patients who are comparatively better and can be seen later. And black patients are basically patients who have already deceased. Okay. So preparation and triage for the next 2 days. Preparation, triage. Okay, now coming to our main topic, primary surgery. The A, B, C, D, E of any resuscitation, not just trauma patients. Any resuscitation, A, B, C, D, E is everything. So when we were young, when we were learning English, we started with ABC, right? Now that we are learning about trauma and emergency care, we have to again start with ABC. So what is this A, B, C, D, E? A is airway, B breathing, C circulation, D disability, and E is exposure. Okay, there are add-ons to this, but this is the first thing you have to remember. Airway, breathing, circulation, disability, exposure. And the sequence always remains this. You have to first make sure that you go and see the airway first. Why? Can anybody tell me? Because airway will cause severity faster. A patient will die of an airway compromise much quicker. So the airway needs to be number one, followed by breathing, circulation, disability, and exposure. The reason I'm repeating it so many times is because it's that important. Okay. Now, there are certain add-ons to this. So what is an airway? Airway is basically a passage which takes your air into the lungs, right? This airway should be along with the cervical spine motion restriction. So whenever you're managing the airway and the patient has come with trauma, make sure that the spine, the cervical spine, is not moved a lot. Why? We will talk about that later. Breathing needs to be with ventilation. That is proper exchange of gases. Circulation needs to be with hemorrhage control. The 20-year-old boy who came to us, he is bleeding. So before giving crystalloids, you have to go and first stop the blood. You have to go and first stop the hemorrhage, right? Disability is always with neurological evaluation. And exposure is always with an environment control. Now, I don't know how many of, so tell me by the show of hands, how many of you are well versed with ABCDE? How many of you are well versed with ABCDE? Show of hands. That's all. You guys don't know ABCDE. You've never done it. Okay, very few of you. Okay, so I'll start from the basics then. Okay. Now, important thing is, whenever you're doing this ABCD assessment, it's a very time sensitive thing. If a 20-year-old boy has walked in, वो आया, and you're like, ठीक है, आया है, आप देखो अभी मैं, I'll come. No, this is something that needs to be dealt right now. And the assessment should be under 10 seconds. So the more experienced lot here will probably do it in 10 to 20 seconds. People who are just starting in, finish it in 3 to 5 minutes. 3 minutes being your target. Okay, you have to see the airway, you have to see the breathing, circulation, disability, and expose the patient within 3 minutes. Okay, now what is airway? Since many of you have not evaluated earlier and have not gone through this process probably because you're students, let's start from the very basics. Airway is basically, as I told you earlier, imagine a tube that is giving air and that tube is taking the air to the lungs. Now suppose this tube has a block. Do you think the air will reach the lungs? No, there's a block in between. If this tube is cut from the center, do you think the air will reach the lungs? No, there's a gap. So the tube needs to be, the word is patent. The tube needs to be maintained. There should be nothing blocking the flow of air. So airway is what? Starts from your nose, from your mouth, up to your trachea, reaching your lungs, a passage to take air to the lungs. Now, when this patient comes to you, this 20-year-old boy comes to you, how do you assess? आप क्या करेंगे? कैसे assess करेंगे? You will go to the patient and you will be like, hello, sir, get up. How are you? You will start talking to the patient to see if that patient is speaking or not. You will see whether the patient is alert or not. You will see if the patient's speech is labored or not. And if there's any stridor. How many of you know what is stridor? Again, a show of hands, because there's no mic there. Stridor, stridor. Do you guys know what stridor is? At the back? He's saying yes, but he's not raising his hand. Do you know what stridor is? Few of you. Okay. So stridor is basically a very high-pitched voice that comes when there is an obstruction. Now, go back to the tube. Go back to the tube we were talking about. This tube, this tunnel, which is taking air, is now having an obstruction somewhere. So there is a very small passage left. So all the air that should come from the entire tube is now going from this very small passage. So it will be, so the voice that will be generated will be very high pitched, squeaky kind of a noise. That is called stridor. If you have never seen it, I would say go back home, go on YouTube and hear what a stridor sounds like. Okay. So you have to look for stridor to see if there's any obstruction. And then you have to see whether there's any facial injuries, there is any injuries to the neck or not. So you have to act like these monkeys. You have to first see. So what are you seeing? You are seeing if the patient is having any injuries. इनको सर पे लगा है, ठीक है. 20-year-old boy सर पे चोट लगी. Face पे there is nothing, but there is injury somewhere in the neck. So you see for the injuries first. Number 2, you speak to the patient. How are you? Are you okay? And if the patient replies to you, that means the airway is good. It's patent. Because how do we generate speech? आवाज कैसे बनती है? Air goes through the vocal cord, right? So if there's any blockage in this tube, proper voice will not be generated. Number 3, you try to listen. What? For the stridor. Is the stridor there? Is the stridor not there? So you have to see, you have to speak, you have to listen. And then you make your decision whether this airway needs management or not. Okay, this 20-year-old boy, which we just received, is not speaking. He's not responding. So do you think his airway is patent? Do you think his airway is okay? No. Okay. So the 2 points I want you to remember, these 2 points, even if you forget my entire lecture, just remember these 2 points. Number 1, if the patient is talking to you, the airway is okay. The airway is patent. If the patient is responding and talking and the speech is normal, the airway is patent. And number 2, GCF is something that we'll deal with later. But what I want you to understand is if the patient is alert, अगर वो उठे हुए हैं, अच्छे से respond कर रहे हैं, that also means that the patient's airway is okay. But our patient is drowsy. He's not responding. He's not alert. That means this patient will require an advanced airway management. Okay. So any patient who's not alert, who's not phonating, might need an airway management. So airway will also be dealt in further lectures in detail. But I just want you to understand just very, very basic points. Whenever you're managing airway, the first thing you want to do is कोई भी obstruction. अब जैसे ये जो हमारे पास patient आए हैं, he is a patient of trauma. So there is a possibility that he has had facial trauma as well. There must be blood pooled in his mouth. So you want to do suctioning, right? To do suctioning, you need the mouth to open. You need a proper position. So to get the patient in that proper position where the mouth is open, there are 2 things you can do. And this is not something only a doctor needs to do. This is something all the nurse, even an untrained person can do, right? So first is head tilt, chin lift. Basically, you tilt the head, lift the chin. The moment you do that, try to do that when you see a patient next who is not conscious, who is not alert. Whenever you are tilting the head back and you are trying to lift the chin up, the mouth will open. Okay, the airway will be maintained, and then you can go ahead and do your suctioning. This is specifically for patients who are not alert, who are drowsy. Okay. The other maneuver is jaw thrust. So sometimes what happens, as I told you earlier, जब head में injury होती है, there is a chance that cervical spine is involved. उस cases में आप सर को ज़्यादा move नहीं कर सकते. You can't go ahead and do a head tilt. In those cases, you go for something called as a jaw thrust, where you go give some thrust here and try to open the mouth by giving a jaw thrust. Again, this will be dealt with later. But understand the terminologies, because many of you have not dealt with these patients. So understand the terminologies, remember the terminologies. Head tilt, chin lift, and jaw thrust. So head tilt, chin lift, you will do for patients probably who have not undergone trauma and you want to maintain the airway. Any patients with trauma, you will think of the cervical spine and do a jaw thrust. You will not move the head a lot. Okay. Now, please tell me who have heard of oropharyngeal and nasopharyngeal airways by the show of hands. This at least 2 people might. Now everybody is raising their hand. Good. So I'm not going into the detail of that. Oropharyngeal airway is basically a device to avoid your tongue to fall back, to keep your airway patent. And it is basically used in patients who are not conscious. So how do you differentiate? Kisme OPA dena hai, kisme NPA dena hai? A patient who needs NPA will be conscious. A patient who needs OPA will be drowsy. Because OPA aapne dekha hai na, when you put an OPA, what will it do? It will irritate. If somebody has a cuff and gag intact, you can't go ahead and put an OPA. It will irritate the patient. Gag ho jayega, so he might want to puke. Puke karenge, so that puke can go into the lungs and the patient might aspirate. So OPA is for patients who are drowsy. NPA is for patients drowsy or who are conscious. It can be given in either. Okay. These are the different OPA and NPA. They all come in different sizes. This will also be discussed later. I just want you to understand that if a patient comes to you and you can't do anything else, you don't know how to intubate, you don't know how to do a tracheostomy, this is the easiest way to manage the airway. Do a head tilt, chin lift, and put an OPA if the patient is drowsy. You can suction this patient and you can maintain the airway with AMBU. अगर आप 1 घंटे तक भी airway को maintain करना चाहते हैं without intubation, you can do that till somebody who's trained in intubation walks in. This is that important. So this will be again discussed in your airway class, but the importance of this is very significant. Okay, now there's something called as definitive airway, which basically means a tube is placed below the vocal cords. That is definitive airway. Okay, so if a tube has undergone gone below the vocal cords, there are 3 main types of definitive airway that are there with us. Okay, so one is an orotracheal tube, which is normal intubation tube. You people have heard of intubation, right? Yes? Okay. So tube is inserted in the trachea below the vocal cords. That's a orotracheal tube. The other tube is a nasotracheal tube, where you basically intubate the patient through the nose. And the third is a surgical airway, where you basically insert a tube directly from the neck. That is tracheostomy or cricothyroidectomy. These 3 definitive airways are used in patients who are not alert, who are GCS is low. GCS is Glasgow Coma Scale. Okay. You have heard of GCS? With a show of hand, please tell me. Oh, great. So GCS of less than 8 is basically an indication to intubate. If a patient comes in and you don't know कि इनको intubate करना चाहिए या नहीं, definitive airway is required or not, just calculate the GCS, and any GCS of less than 8, as I discussed in the last slide, will require a advanced airway. Okay, now something very important is your cervical spine immobility that is required in the patients. So now I want your attention, everybody. Attention, please. This is important. Okay. Your cervical spine is a very, very precarious area. There are very important structures in the cervical area. Number one, there is a sympathetic chain. अगर उसमें damage होगा, if the sympathetic chain is damaged, you will develop shock. What kind of shock? That will be neurogenic shock. Okay. So sympathetic chain 1. Number 2, phrenic nerve. Phrenic nerve is the nerve जिसका root cervical spine से generate होता है. And where does it go and supply? To the diaphragm. So if the phrenic nerve is injured, will the patient breathe? No, because the diaphragm, the main muscle of breathing, will not be working, will not be moving. What else is there? Obviously the spinal cord. Okay, the spinal cord runs through. So from the cervical spine to the lumbar area, there is a chance of a spinal cord injury. If there's an injury in any of these places, the patient can be paralyzed. That is called a spinal shock, where the patient is paralyzed. When the patient is not paralyzed, there's a cervical injury and the patient's blood pressure has fallen down, then it is called a neurogenic shock. That's why the cervical area is so important. Okay. So if we have an injury in the cervical area and we are moving the patient, we are doing the head tilt, chin lift, and we are moving the patient's head a lot, what will happen? The shock can worsen. The patient has already lost blood and now we are moving his head. So the injury can be increased and the patient can land up in neurogenic shock. Okay. That's why when a patient of head injury comes to us, a patient of polytrauma comes to us, we have to make sure that we are putting a cervical collar. What does the cervical collar do? It will help restricting the motion. So now what will happen? Till we rule out a cervical injury, we have to keep this collar in place. Okay, this is very important. Please, whenever you are managing a polytrauma, always think of a cervical collar. Always. Okay. So breathing is relatively easy for us. We can monitor the SpO2 from the pulse oximetry. We can auscultate the patient and hear for breath sounds. We can see whether the patient is breathing very heavily. So we'll see the RR. So breathing is something that we anyways do on daily basis. Okay. Along with that, the only thing that is added in trauma is to see for chest wall injuries. So what are the injuries that can happen? Anybody? The lung can get injured, which can lead to pneumothorax, hemothorax. Have you people heard of pneumothorax? Show of hands. Okay, so most of it, yeah. So the patient might develop pneumo or hemothorax. Patient can develop rib fracture. Okay, so the ribs can be affected, the lungs can be affected, or just the chest wall can be affected. Also, there are some important vessels that are passing through. There is a trachea, the tube that is taking your air to the lungs is going through. So the major structures can also be affected. So in the breathing part also, you will first see whether there is any injury there. Then you will hear, palpate, and then hear for auscultation the breath sounds. And again, you will talk to the patient because you want to see whether he is talking normally or he's having a labored, speech. Okay, so that is how you evaluate your breathing. Okay, circulation far easy than airway. Basically, there is a trauma. The patient has lost a lot of blood. So the amount of blood volume that should be there in our vessels is not there. So what do we have to do? We have to give We have to give crystalloids. Okay. So we have to give blood volume. So when you have to increase the volume because the patient has bled a lot, will you have a blood just lying around? No. So the moment the patient walks in and you see that the patient has bled, the first thing you do is to secure your IV line. Take 2 large IV cannulas. Once you have taken the IV cannulas, they are in place. The moment you get the IV line in, collect the blood sample, send for cross-matching. Okay. Send for cross-matching. Okay. Then once you've sent for cross-matching, you can wait for the blood, and in the meantime, you give 1 liter of crystalloids. So 1 liter of crystalloids, that is 2 pints of your normal NS, is absolutely okay. But over that, giving too much crystalloids to a patient can be harmful to the kidneys and can be harmful for the coagulation because the coagulation factors get diluted. So once that 1 liter has been given, make sure that along with fluids, if the patient is still losing blood, you replace blood with blood. Okay. Now another important slide. Attention everybody, please. If the patient is bleeding, always think if the patient is bleeding outside, he might be bleeding inside as well. Something that you can't see. That is called 1 on the floor and 4 more. If the patient is bleeding outside, if you can see the blood outside, there is a possibility the patient is also bleeding inside. So what are the 4 areas the patient might be bleeding in? Lungs, abdomen, pelvis, and long bones. Okay. So the moment you see blood, auscultate, check the tenderness in the abdomen, check guarding rigidity in the abdomen, check the pelvis if it's stable or not, and palpate the long bones. Is there any swelling? Is there any possibility of bleeding? So the line here is 1 on the floor, 4 more. So you have to see for those 4 cavities internally. Management, we've already discussed. You put 2 large IV bore cannulas, give crystalloids followed by blood. Okay. One small point here is tranexamic acid. Tranexamic acid is basically an antifibrinolytic agent which helps in reducing the loss of blood and helps with coagulation. So this can be given up to 3 hours, but ideally should be given within an hour. Okay. Okay, so disability more or less involves your neurological assessment. Since you all are well versed with GCS, I'm not diving into GCS. Are you all also versed with AVPU? With a show of hands. Okay, so AVPU is a simpler form of assessing somebody's consciousness. It's simpler than GCS. A is awake, B is verbal, P is pain, U is unresponsive. So if the patient is awake, it's A. Patient responds to verbal stimulus, V. Patient responds to painful stimulus, P. And if he's unresponsive, U. So the 20-year-old boy who came to us, he was not responding. So he is U. Okay. That's how you categorize AVPU. It's an easier score and it helps in reassessing the patient over and over again. Along with that, in disability, you should see the pupillary size. You should see if there's any spinal injury, if there's any lateralizing signs or not. GCS, again, I'm not going into details since most of you know what GCS is. The main point you take away from this lecture is GCS less than 8, intubate. You have to put a definitive airway. GCS less than 8, you have to put a definitive airway. Okay. Exposure may most important is to look for other injuries that you might have missed earlier. You can do something that is called a log roll, where you look if you've missed any injuries at the back. Okay. So basically exposing the patient is derobing the patient and then checking for injuries. When you do that, there is a possibility, especially in the colder areas, to develop hypothermia. तो ठंड से बचने के लिए हम यूजुअली क्या करते हैं, ब्लैंकेट लेते हैं. So similarly here you can give warm blankets to these patients to prevent hypothermia. Okay. And important thing that I want to just touch upon is, that's a little bit of theory, but I want to touch upon is, any patient who develops hypothermia, can you see the triangle there? Any patient who develops hypothermia can develop coagulopathy, and coagulopathy can develop acidosis. So it's a triad of death. So hypothermia is that grave. So whenever you are derobing the patient, keep your, even if you don't have the warm blankets with you or a warmer with you, keep regular blankets and try and cover the patient quickly after you have assessed the patient. Now quickly coming to the adjuncts. Adjuncts is something that we are very well aware of. 20-year-old boy, unconscious. We've already managed his airway, right? What are the adjuncts we used for this patient? When the patient was wheeled in, we applied monitors. So that is 24/7 ECG monitoring. Number 2, you put pulse oximeter to monitor the saturation. What is capnography? How many of you know capnography? I want to know whether, okay, at the back, capnography. Okay, so capnography is very important. It's called EtCO2. Heard of EtCO2? Okay. So basically, when we are expiring CO2 out, we measure how much CO2 we are expiring out. That is your EtCO2. Okay, and that will basically guide us a lot when we are resuscitating a patient. Also, when we put the ET tube in, to know the placement of the tube, EtCO2 comes in handy. Okay, it's a small sensor that you can connect, and it will help us know whether the ET tube is in place or not. Because if the CO2 levels are high, that means the air exchange is good. That means your ET tube is in place. Okay. ABG, blood gas, everybody is aware of that. Arterial blood gas is also an adjunct which helps us know whether it's acidosis or not. Okay, then catheters. Just one thing I want all of you to remember, another important point, get up. Okay, another important point, if there is blood in the meatus when you are assessing the patient, if there's even slight blood in the meatus, don't put a urinary catheter. अगर डॉक्टर लगाने जा रहा है, आप मना कर दो, हम आपको असेस नहीं करेंगे. Because if there's blood there is a possible urethral injury, and that will be increased when you're putting a urinary catheter in. Okay. And the other important point is, if the patient has a possible injury to the base of skull, there are certain signs that you can know. There will be raccoon eyes. Okay, there will be a hemotympanum. There will be blood collected over here. Okay, so if there is any signs of base of skull fracture, don't put a RT through the nose. Put it through the mouth. These are two important nursing points. If the doctor is doing a mistake, you point it out. Okay. Then X-ray of the chest, of the pelvis, and FAST, that is focus assessment with sonography in trauma. These are the only 3 tests that are allowed in primary survey. When you are assessing the airway, breathing, circulation, disability, exposure, you are not going for a CT scan. You're not. You don't have that time. Because while you are assessing, you're also managing. आपने airway देखा, patent नहीं है, आपने intubate किया. You're seeing that there's a breathing difficulty, you put a ventilator. You see he's lost blood, you start giving blood. But you don't have that time to do advanced tests. There are only 3 tests you can do. Chest and pelvic X-ray, portable obviously, and a FAST scan. Chest X-ray will help us know whether there is any air that has leaked in pneumothorax or blood that has leaked in hemothorax. Pelvis X-ray will help us know whether there's any fracture in the pelvis, because remember, a fracture in the pelvis can use up to 2000 or more ml of blood. So the patient can go into severe hemorrhagic shock. Okay, and then FAST is basically a way to see if there's any collected blood in the abdomen and thorax. So these are the only 3 tests. So I'm concluding this session, and in the summary, there are a few points that I want you to definitely take away from this class. One, to always follow A, B, C, D, E. Then always try and complete your primary survey quickly. In more experienced people, under 10 to 20 seconds. Then talk to the patient. If the patient is talking, the airway is patent. 2 large bore IV cannulas, all trauma patient. दिमाग में ऐसे lock करो. You see a trauma patient, put 2 large bore IV cannulas. GCS less than 8 requires a definitive airway. And adjuncts, all the adjuncts that we mentioned, whether it's ECG, X-ray, or the FAST, will help us reach a diagnosis faster. So make sure that the adjuncts are done on time. Thank you.
Thank you, Dr. Varnika Kala. That was really an excellent explanation of the primary survey. I request Mrs. Vandana Kumari, Associate Professor, MGM New Bombay College of Nursing, to appreciate her with a certificate. I'm very excited to introduce the next speaker of the day. He has been a nurse consultant for more than 2 decades. He completed his basic education in St. Joseph College, Devri, Kozhikode. He obtained his basic BSc Nursing degree from prestigious Father Muller College of Nursing, Bangalore, with first rank in university. He's very humble. He's asking me to read little only, but let me read because it is a very interesting CV. He was also the best outgoing student. No problem. During his undergraduate program, he obtained master's degree in medical surgical nursing. He has been awarded PhD degree. He has many publications, many awards to his credit. So he's a very eminent personality who has accepted our invitation humbly and has come today. So Dr. Sajid Kumar P, RN MSN PhD, Regional Faculty, American Heart Association. Currently, he is working as Assistant Professor and Lead Faculty, Advanced Skill Lab, Government College of Nursing, Government Medical College, Kozhikode, Kerala. So, I request Director Dr. Prabhakar Dasila, MGM New Bombay College of Nursing, to felicitate Dr. Sajid Kumar P.
A very good morning. So happy to be here. This is my second visit to MGM. In 2022 June, I spent 5 valuable days here. I'm so happy to be here again and again. Since we are 15 minutes back the schedule, I just want to quickly browse through the most important aspects of secondary survey and adjuncts. And what a wonderful and comprehensive session we had on primary survey and adjuncts. Since this is a continuation of the session that we had, it becomes very easy for me. So we'll try to finish by 10:45. Oh. Would like to mention a few names here. During the tough times of COVID, we were helped by some of the nurse practitioners from MGM. I do gratefully remember two of them, and one of them is sitting here, Mr. Jignesh and Sridevi Nambiar, who has migrated to United States. They were helping us in conducting various sessions for nurse practitioners working in the country. And what tough times we had throughout. And at the very outset, I would like to thank MGM, the principal and the entire organizing team. What a wonderful team Madam has, for choosing the most appropriate topic, which is the need of the hour. And rest of them are my mentors, who are the reasons that I am today here. So next few minutes, I would like to highlight the purpose and importance of secondary survey. What are the steps in secondary survey? Secondary survey in vulnerable population, and how do we connect the secondary survey and mechanism of injury? Very happy to see so many of the students here. These are essential knowledge that we need to inculcate from first semester itself. So it is nice that most of you are here today. I do remember a case scenario. This is the real anecdote. I didn't create this scenario. One of the nursing students who was in third year before we started the semester system, she has come for a educational visit as a part of the psychiatric nursing posting. And she was hit by a heavy motor bullet, Enfield 350, that's what I remember. And she was brought to our emergency room. I am in academics, I was teaching at that time. Since it was a nursing student, I was also informed and I came to the emergency room. Within 5-10 minutes, I have reached. When I reached the emergency room, I was so happy to see that she was intubated. There was, I think a Thomas splint was also put on her right lower extremity. So immediately I asked people who were taking care, what is the initial rhythm? How is the patient now? Unfortunately, the monitors were not connected. One doctor had immobilized her spine manually. So I was checking her pulse and the peripheral pulse was so feeble. Check the central pulse. I could barely feel that. Patient was already in a cardiac arrest. In the emergency room, actually they have proceeded to a detailed examination without giving emphasis for the immediate life threats. There comes the importance of the primary survey and adjuncts. Without doing a proper primary survey, primary survey basically looks at the immediate life threats. Without stabilizing the patient, they have gone to put a immobilization for the extremity trauma. This happens very often because some of the trauma are distracting. They distract us from the real injuries. Actually, this patient had an abdominal injury. If a person is hit by a bike, where can be the injury? Either where is the point of contact? If the tire is hitting, probably you have to think about an extremity trauma. Suppose the handlebar is getting hit based on the person's height, either the abdomen or the pelvic injuries you have to expect. But nothing of this sort was thought in the beginning. That means we didn't relate the mechanism of injury with the injuries of the patient. So what happened? Patient was profusely bleeding inside the abdomen that nobody could recognize. Madam mentioned about exposure. We had to examine the abdomen to understand whether there are any changes, and it is a very tough area to examine because very late the manifestations of abdominal trauma will come out. So ultimately what has happened? Patient has gone to a trauma cardiac arrest because of very less volume of blood. And I do remember later I could understand there only one brother who is doing MD forensic medicine in our own hospital, our own medical college. So our own person is lost because we didn't pay attention to the details. If the emphasis of the primary survey is on the immediate life threats, in secondary survey, it is a very detailed and comprehensive examination. That is why we don't proceed to the secondary survey until we exclude the possibility of any life threats. At times, we may start a part of the secondary survey along with the primary survey if it is an excellent trauma team. So a group of people will be focusing on the primary survey and another group of people can focus on the secondary survey, provided there should not be any interference with the primary survey or resuscitation of the patient. Now, what are the major things that we need to observe while performing a secondary survey? As I already mentioned, we need to draw some clues from the mechanism of injury. So it is very easy for us to predict the injuries. I just mentioned about a motor vehicle collision. So we will be coming to this in detail a bit later. So what are some of the elements of the secondary survey? What are you going to do in the secondary survey? It is time consuming. If you have to do primary survey as early as possible and stabilize the patient, here it's a bit more detailed and comprehensive exam. First thing that you do is you review the primary survey because you just want to ensure there are no life threats. Then you have to take a focused history of the patient. You know, being nurses, we are very good in history, right? In the first semester, I have seen the students coming to the ward and they are focusing more on the IPR and TPR, very good in history. But we don't have that much time to collect the entire history. Rather, we go for a very focused history in trauma patient. Also, we do a head-to-toe detailed examination, and we have a system of doing that. And finally, you will proceed to some of the adjuncts and review of the diagnostic studies. You remember, we have very few things that we need to do in primary survey as adjuncts. Madam was talking about the ABG and ECG, two tubes, if you remember. What were the two tubes Madam mentioned? The urinary catheter and the gastric tube. What else? Few X-rays Madam mentioned, remember? Yeah, the chest X-ray and the pelvic X-ray and also the fast examination. So we are very focused because our focus is mainly on the life threats. Don't think that we can elicit all the problems in the primary survey because it is a very quick survey. Rather, remaining things, remaining specific diagnostics you have to consider during the secondary survey. So I just mentioned we start the secondary survey by reviewing or repeating the primary assessment or the initial assessment. So check the vital signs. It's very, very important. And do a head-to-toe examination by using a mnemonic. I'll be explaining this. DCAP, BLS, TIC, so that we don't forget any of these things. So you review the findings of the primary survey. At any point, you understand there is a life threat, stabilize it, don't proceed to the secondary survey. So what are the main things that you look into when you take a focused or targeted history? The first few, there are a few changes when we consider the pre-hospital and in-hospital trauma systems. Most of us who work in the in-hospital facility, we use the ATLS protocol. It's a little different, and I have incorporated a part of the pre-hospital system also, because in trauma management, the first few minutes that we spend in the pre-hospital time is also vital. We usually refer what is called as the golden hour, but we do not have that many time. The first 10 minutes in trauma is called as platinum 10 minutes, and what you do is vitally important. So the first S stands for the signs and symptoms the patient has now, what you observe. A stands, as most of you know all these things, allergies. M stands for the medications and the last dose and time. P for the past medical history. L for the last oral intake. At times, if the person is in the reproductive age group, we also will think about the possibility of a pregnancy. So maybe we can incorporate what you called as last menstrual period there. And E stands for the events preceding the incident. So quickly you are trying to get a focused history of the patient. And then you proceed to a very comprehensive and systematic head-to-toe examination. So this is how you approach each area, from the head till the toe. The DCAP, BLS, and TIC. D for the deformities, contusions, aberrations, penetrations. It's very easy to remember. DCAP, BLS, TIC in each area. Burns, laceration, and swelling. Tenderness, instability, and crepitation. This is what you are going to look at each place as you examine. Please understand, it is a more comprehensive exam. And your decision when to start the secondary survey also is very important. If you are in the pre-hospital area, for critical patient, try to do as you transport the patient to a definitive trauma center. If it is a short transport, don't try to go for a secondary survey. Rather, you continue or you review the primary survey, which is called as ongoing evaluation, so that patient should not deteriorate. If it is non-critical patients, definitely you have no issues. You have enough time to do that. Now, let me use a part of the International Trauma Life Support algorithm for the secondary survey. You see that it is done, after patient is getting stabilized. After the initial assessment is being done, a focused trauma survey is done. Once the patient is stabilized, we proceed to the detailed examination. I told you, you repeat the initial assessment. Consider using all possible monitors, which give us a lot of help because we are in a hurry. You record vital signs. I'm very sure some of you might not be very happy to hear this vital signs term, because as a nursing student, I have experienced this. The moment you are in the clinical area from your first year onwards, the seniors ask us to check the vital signs. I thought when I become second year, things will change. When I reached second year also, they asked me to check the vital signs. Third year and fourth year, this repeated. So I understand some of us have some sort of, a reluctance to check the vital signs. But remember, for trauma patient, vital signs are vital. Do a quick neurologic examination, a brief neurologic examination. Madam has already mentioned about that. But here a little more in detail, you have to check the level of consciousness. As Madam rightly mentioned, you have to check the AVPU scale. And if the patient is somewhere below the alert level, you may have to go for a detailed GCS examination here. Check the pupils. Check the motor activity. Ask the patient to move the extremities. Also look for the sensation in the extremities. So these are all vitally important. Then you start the head to toe quick evaluation from head, and I will take each one into the details. First, you look into the head. So what is our mnemonic? What are you going to look at the head? It's easy. It is DCAP, BLS, TIs. So into the details, you palpate the head. All your physical examination measures you may use. You may inspect, you may palpate. At times, certain body parts you may percuss, and also you may auscultate whenever required. So what are the important things that you look at the head? The life threats are already been excluded. Now you look whether there are any bleeding, any fractures. Probably you may see the manifestations of basal skull fracture like raccoon eye or battle sign. There can be CSF, rhinorrhea or otorrhea, any bleeding, any anatomical differences you will be observing in the head. Definitely you look into the neck, you see the trachea, the large veins, the carotid pulsation, and also very important area of the posterior aspect of the neck, because you need to see if the cervical spine is not stabilized in the pre-hospital area, you may have to do it now. Go to the chest. There can be, most of the polytrauma patients, 25 to 40% of polytrauma patients will have head injury. Similar way, there can be the thoracic injury also, and see that you inspect, you palpate and auscultate. If required, you percuss the chest. Madam mentioned some of them, and I will be elaborating a little bit on the thoracic trauma to give you an example of how comprehensively the secondary assessment is done. And abdomen is a very tough area to evaluate. You see whether there are any signs of the blunt injuries. Penetrating injuries, we are lucky because you can observe then and there. But blunt injuries, the manifestations may develop a little later, very difficult. And now you don't understand whether the abdomen is distended because of a trauma, or is it a normal thing like me? Most of us are globalized now. That is another issue that we come across. Then definitely proceed to the pelvis. Madam mentioned about that. You see whether there is any instability with the pelvis. They are all very dangerous areas. I have seen in the abdomen 2 to 2.5 liters of blood. Patient has gone to hemorrhagic shock. Similar findings can be seen in pelvic trauma, because when the pelvis gets fractured, we see that there are multiple fractures in the pelvis. Each fracture will cause almost 500 to 750 ml of blood. There can be 4 or 5 fractures. Then imagine almost 3 liters of blood is lost. How we are going to rescue the person? So it is vitally important to check the pelvis. Extremities. Madam mentioned, if you remember, on the floor and 4 more, and one among them was the long bones, especially the femur. Femur also can cause one femur fracture. We have seen almost 1 to 1.5 liters of blood loss. Think about a bilateral femur fracture, that itself can kill. So examine the extremity. First, the lower extremity, look for the pulsation, the distal pulse, the sensation and motor activity in the distal area. Look for the upper extremity too. And very important part is the posterior aspect, if you can see. See, the same surface area, just like our anterior body, we have in the posterior aspect also. But many a time, this area is neglected. So turn the patient, in a very systematic manner, what you call it as a log roll, if you suspect a cervical or lumbar or any spine injury, and examine the spine, literally palpating the spine. You can see the picture there. And don't forget to look into very sensitive and neglected areas like the perineum, the gluteal region. I do remember very recently a case brought to my medical college. There was bleeding, but we couldn't identify from where it is coming. But when we turned the patient to the other side, there was a stab injury into the gluteal region. That is very rare, right? Most of the stab injuries are on the abdomen or on the chest. But here, thing was different. So don't forget to look into each area by using the mnemonic DCAP BLS TIC. Don't forget this. Now, I just want to emphasize how important is the secondary survey coming and identifying the life threats, because since we have stipulated cutoff time, we cannot elaborate the entire thing. I thought I will choose the thoracic injury to illustrate in a very brief manner how the secondary survey is important. We know there are 12 deadly cases when it comes to the thoracic trauma. You call it as deadly dozen in thoracic trauma. And the 6 of them, what you can see now, that is usually identified in a primary survey itself. The airway obstruction, flail chest. So how will you understand the flail chest? As you examine the patient in the primary survey, as you see the breathing pattern, you understand a part of the thorax is not participating in the normal breathing. When we inhale, usually what happens, the thoracic cage come up. But if the patient has a flail chest, there will be something called as the paradoxical movement of the chest. That part will be going down. So you understand there is a flail chest, and there are all possibility for a open pneumothorax, massive hemothorax, tension pneumothorax, or cardiac tamponade along with a flail segment. But then we are not going into the details during the primary survey. That happens in the secondary survey, and the remaining 6 in the deadly dozen you will be able to identify during the secondary survey. Just like myocardial contusion, the traumatic aortic rupture, brachial or bronchial tree injuries, the diaphragmatic tears, pulmonary contusion, and blast injuries. I'm sure in the afternoon skill station, we'll be able to elaborate more on that, because I'll be talking more on, I'll be demonstrating you some of the important X-rays and CT interpretation skills as far as the trauma is concerned. That is actually another 1 week of workshop that is cut short into 45 minutes. Now, look at the myocardial contusion and understand this is the most common cardiac injury because of the blunt chest injury. See that you may not understand during the quick primary survey, only a detailed secondary survey will reveal this. So consider just like a myocardial infarction in this case. There can be chances of arrhythmia. So I already mentioned that all monitors will be of immense help. Traumatic aortic rupture, the most common cause of immediate death. Most of them, 80% of them, they die immediately. And remember the scene size in the pre-hospital. I think we have a lot of role in the pre-hospital care also. When we go abroad and see they have an excellent emergency medical service system practicing, I always think the nurses have a very important role in our country to establish the EMS system. So there can be no obvious signs of chest trauma as you see the primary survey. But when you do a detailed examination, you understand there are some changes that can be seen. Again, the tracheal or bronchial tree injury, same way, in the secondary survey, you will be able to elicit more. Similar way, the diaphragmatic tear, in which there can be herniation of abdominal organs. When you do a detailed examination, you will come to know. The pulmonary contusion, again, I'll show a real case of pulmonary contusion. The chest X-ray and CT scan in the afternoon. Also the blast injury, which is not very uncommon in our country, especially my part of the country, people are a bit aggressive, and due to political reasons, we very, very often get blast injury patients. Now, remember, if secondary survey is not done properly, any part of the body can be affected. And the most important part is the brain, because hypotension and hypoxia can be the 2 lethal issues that we confront in head injury. Please remember, for all other injury patients, you don't need to keep the BP very high. Only till you get a palpable peripheral pulse, we keep the BP. But for head injury patients, how important is the secondary survey and ongoing examination? Because hypotension is the single instance that increases the mortality. For these patients, we may have to keep the systolic BP a bit high. How important is the nursing care in these cases? What a role is performed by nurse practitioners in this area? So, since we are running short of time, I would like to proceed to the vulnerable population and secondary survey. Please see that when you deal with the children, elderly, pregnant women, and this is a very deadly combination, the substance use and trauma. All these patients, you call them as impaired patients. You need to be extremely cautious when you do the secondary survey for these people. So how important is to alter some steps of secondary survey in children? You may need to interact. I have great respect to pediatric nurses actually. It's not easy to interact with them and manage the children. So see that you should be familiar with the common injuries in children, and your interaction strategies also should be very good. The geriatric population, again, their general body systems and the changes along with the elderly population also you have to take into account. Many of them, they say, we are okay when you interact with them, but they suddenly deteriorate. So you should anticipate problems for them, even though they look to be very okay during your initial assessment. So do not underestimate the severity because they die from less severe injuries. Now, trauma in pregnancy here, you are dealing with the two lives, the mother and the unborn fetus. So hypotension and hemorrhage usually easily overlooked, and you may sometimes confuse with the normal physiological changes of pregnancy with the signs of shock. So we need to be extremely cautious while dealing with the pregnant woman also. Impaired patient, I was just referring to what you call them as patients with the substance use. It will be very difficult for you to recognize, is it because of the substance they are showing the manifestation, or is it because of the trauma? So that will be one trouble when we do the assessment. And again, you may have to use intelligently your interaction strategies with them. Not easy. You know, some of them, they may not cooperate. So if you are in the pre-hospital or you are in a first referral unit, your critical transport decision is important. They are all low threshold for early transport. Remember about, before I conclude, I would like to quickly take you through the adjuncts. So all the specific diagnostic tests, other than what we have used in the primary survey, you call it as an adjunct in secondary survey. At any moment in time, you think that there are life threats, stop, treat problems as you see. This is called as a fix it, then and there approach. So one of us in the trauma team, the team leader will be usually doing the assessment, and he will be delegating the responsibilities because we are not completely assessing and then starting managing. As you see problems, you have to manage. So do not delay any life-saving intervention and transfer to the trauma care unit. So what do you understand from this trauma scene? You look at the vehicle injury. So you get some clues from the trauma scene. If you have a very good pre-hospital care, the EMS team is giving you a handover, how it has happened. You can definitely understand where you have to expect the injuries. So there can be blunt injuries or penetrating injuries. Look at this. So the first one is the machine collision. As you know, as per the Newton's law, even if the machine is stopped, you may continue to move at a speed of 90 kilometers or 100 kilometers in which the vehicle was moving. So the next thing what is happening is the body collision until the foreign object is stopping you. And at that moment also, our organs are moving at a speed of 90 to 100 kilometers, and you see that there is an organ collision. Once you don't understand this mechanism, okay, of injury, say for example, you see that, or the EMS person is telling you that the steering column is completely collapsed, you understand there is a severe chest trauma and head injury. And remember, some people keep very good objects in the back side, in the rear side. I don't know whether you have seen. People keep very hard wooden, boxes, beautiful thing to keep tissue paper and all those things. And that objects also will be coming and hitting the person. These are called as secondary collisions. So remember, deformity of the vehicle, deformity of the interior structures of the vehicle, deformity or injury patterns on the patient, these are all interrelated. So you will have a clue what anatomic areas were hit. Very often we get pedestrian injuries, as I mentioned, what type of vehicle has hit, that gives falls, again, another type of mechanism of injury. Penetrating injury, where is the, the impact now? This is not a professional type of attempt here. You see, somehow they have done a attack. Okay, usually when women attack people, this is something like this. Thoracic injuries are very common. When men attack, it will be usually abdominal injuries. From my part of the country, I can talk very authentically about this. So look at this. This is a thoracic injury, but where is the knife now? Knife has gone to the abdomen. So sometimes thoracic injuries are abdominal injuries and abdominal injuries vice versa. Again, firearms, the type of weapon, whether what type of caliber or missile size, the distance traveled, or make a. So usually penetrating wounds, they attract us, but blunt injuries will not usually attract us. So the wound ballistics also, so you understand, if you really want to understand the trauma and secondary assessment, you need to be an expert in all these areas also. The blast injuries, again, there are different types and phases. Madam mentioned about the Glasgow Coma Scale that comes in the secondary survey. When in doubt, you transport early. So these are the critical interventions as you do the secondary assessment. You manage the airway, you assist the ventilation, administer oxygen whenever patient goes to cardiac arrest. Remember, trauma cardiac arrest, it's not very good. You don't get the patients usually back. Control major external bleeding, seal sucking chest, stabilize the flail segment, decompress tension pneumothorax, stabilize the impaled object, and complete the package. I once again congratulate the organizers for choosing this most appropriate topic and urge all the delegates, especially the students, maybe I don't know which semester you are in, but the early, the better. We have to catch them young, inculcate all these things in the very early of the professional life, never stop learning. Thank you very much.
Thank you, sir, for the energetic, excellent presentation. I request our director, Dr. Prabhakar Dasila, MGM New Bombay College of Nursing, to appreciate him with a certificate.
So, madam, can you go ahead?
So moving ahead with the inaugural session of the national workshop, may I request Dr. Purchitra R, Professor and Vice Principal, MGM New Bombay College of Nursing, to come on the stage and join me.
Thank you, Valencia. And good morning to all the esteemed dignitaries, guests, delegates who are seated here, as well as those who have joined online. It's with great pleasure and excitement that I extend you all a warm welcome to the 12th National Conference organized by MGM New Bombay College of Nursing. To initiate with the inauguration, I'll brief in short about the organization to the delegates who have joined us from outside MGM IHS. So Mahatma Gandhi Institute of Health Sciences was acquired, deemed to be university status in the year 2006. The university is accredited NAC with grade A++ and also has scored with category 1 and 12B status by UGC. The MGM Trust has initiated the medical college since 1989 in Kamote and in Aurangabad since 1990 and in Vashi since 2023. The university is further still expanding its campuses, new campuses in Mumbai and Navi Mumbai. The university also offers fellowship programs, allied health sciences by biomedical sciences, physiotherapy, prosthetics and orthotics, and pharmacy. MGM New Bombay College of Nursing is a constituent unit of MGM IHS, had its inception in 2008 and has gone profoundly from postgraduate and the PhD program. The institution is one of the few institutions who is offering the nurse practitioner in critical care postgraduate residency program from the academic year 2017 onwards. And so far, there are 19 nurse practitioner graduates who are graduated from MGM IHS, and currently there are 20 nurse practitioner students who are on roll being trained. And the university has also proposed for nurse practitioner in emergency and trauma care from the academic year 23-24 onwards. And from the inception of this NPCC program, the institution has taken initiative to organize the national skill-based workshop for the NPCC grad students who are there. And today we have gathered here for such a 6th national workshop for the NPCC students. To begin with the inauguration, I will now invite the students of MGM NB and C1 students for the invocation song.
Hello.
तू बुद्धि दे, तू तेज दे, नव चेतना विश्वास दे, तू बुद्धि दे, तू तेज दे, नव चेतना विश्वास दे, जय सत्य सुंदर सर्वथा, जय सत्य सुंदर सर्वथा, आजन्म त्याचा ध्यास दे, तू बुद्धि दे, तू तेज दे, नव चेतना
विश्वास दे हरवलेला काळजांचे होतयांचा सोबती सापडे ना वाट ज्यांना होतयांचा सारथी साधना करीती तुझीच साधना करीती तुझीच नित्य तव सहवास दे जे सत्य सुंदर सर्वता हा जन्म त्याचा ध्यास दे तू बुद्धी दे तू तेज दे नवचेतना विश्वास दे जाणवाया दुर्बलांचे दुःख आणि वेदना देव त्या हो सदा रंध्रातुनी संवेदना भ्रमण्यातल्या हृदयासया खळ भेदण्याची आस दे सामर्थ्य या शब्दाचा आणि अर्थ या जगण्यास दे जे सत्य सुंदर सर्वदा जन्म त्याचा ध्यास दे तू बुद्धी दे तू तेज दे नवचेतना विश्वास दे जे सत्य सुंदर सर्वदा जन्म त्याचा ध्यास दे तू बुद्धी दे तू तेज दे नवचेतना विश्वास दे
Thank you, students. Now may I request Honorable Vice Chancellor, Sir, Dr. Prashant Darvi, Dr. Prabha Dasila, Ma'am, Director Nursing, Dr. Mohanty, Professor Emeritus, Dr. Ashwini Arti, Director, NGM College of Management, and Dr. Dusore, Head of and Dignity Dr. Ajit Kumar to be on stage for lighting the lamp. And all the resource persons who are present here, Dr. Varnika, please be on stage to light the lamp and thank you all. I request the dignitaries to kindly be seated. And now may I request Dr. Prabha K. Basila, Director Nursing, to unfold the theme of the 6th National Workshop organized by NGCON for the nurse practitioners.
Honorable Vice Chancellor, sir. Dr. Mohanty. External expert and all my internal experts from MGM IHS. Dr. Ashwini, Dr. Busare, and dear students. It's my proud privilege to introduce the theme of the 6th annual national workshop organized by MGM New Bombay College of Nursing. It will be on 19th and 20th March at Kamote. I am delighted to acknowledge our external resource persons, Dr. Sajid Kumar, Assistant Professor and Lead Faculty Advanced Lab, Government College of Nursing, Kozhikode, Kerala. Dr. Varnika Kala, Associate Consultant. And we will also have Dr. Akash Sarjogi, Joint Replacement Surgeon from HN Reliance Hospital, Mumbai. Dr. Bhakti Sarang, Professor, Department of Surgery, Tenna Medical College and Hospital, Navi Mumbai. And Dr. Sunil Keshwani, Cosmetic Surgeon, National Burn Center, Navi Mumbai. So they will be there today. And I also happy to acknowledge the resource persons from our own medical college. Dr. Lieutenant General K.R. Salgotra, Hospital Director. Dr. Deepika Sathe, Professor, Department of Anesthesiology. Dr. Lisha Suraj, Professor, Department of Surgery. Dr. Ankita Joshi, Associate Professor, Department of Anesthesiology. Dr. Nikhil Rane, Thoracic Surgeon. Dr. Sanjay Doke, HOD, Department of Traumatology. Dr. Dikpal Singh Jadhav, Associate Professor, Department of Neurology, Neurosurgery, MGM Medical College, Kamote, Navi Mumbai, and our own nurse practitioner from the first batch, Mr. Jignesh Vyas. And we welcome all the participants from our own institution and from different parts of the country. Initially, we thought of having a hands-on workshop with 50 participants participating, but we thought why to keep deprived of all those aspiring candidates from different parts of the country. So we kept it as hybrid. So today, total 255 participants are attending this workshop, which is as sessions and workshop in the afternoon from Maharashtra, Kerala, Tamil Nadu, Haryana, Punjab. From all the states they are participating, and in which there are nursing officers, nurse practitioner students, MSc nursing students, ward in charges, staff nurses working in the critical care areas, and faculty of nursing colleges. Now, already you have attended two wonderful sessions at the start of this day, and you are already learned that sudden illness and injury occur without any warning. And these patients are brought to the emergency department where immediate attention and care is required. A traumatic injury are caused by various forces from outside, which may result in wound, broken bones, internal organs, which you have already witnessed in the first two presentations. And the first 60 minutes are called as golden hour, and which has to be patient attended from outside to inside, and whatever we do in the emergency department. And you have already learned that assessment of such patient is very, very important. It is different from the assessment what you may be usually doing in the wards. So what you do, you have already seen in the primary and secondary survey, which was already dealt with. It is not only managing the patient on time, but managing skillfully is also equally important. Being skilled in managing trauma is a crucial, as trauma patients often require expert attention and specialized care due to severity of their injuries. You have learned that you cannot just turn the patient just like that. Those patients come to the casualty. And all these patients, most of these patients require life-saving interventions. Hence, effective management involving life-saving interventions efficiently. That is very, very important. Another very important aspect of emergency and trauma management is team coordination. It was mentioned in one point also that team coordination, you may be shouting, you may be taking responsibilities, so you have to rush. It is not that just like that you work in the other departments, you can do slowly. You have to have proper coordination, communication, taking the lead in certain things so that seamless care delivery is done to these patients. Competent nurses at the emergency and trauma unit can significantly reduce the mortality and morbidity among trauma patients. For this purpose, MGM New Bombay College of Nursing has organized this annual national workshop, and this workshop will be conducted in 2 full days. So tomorrow till 4:30 it will continue, which will include didactic sessions, which will be in hybrid mode, and hands-on skill stations. So the theme of this workshop is emergency and trauma management by nurse practitioners. So day one, today it started right on time at 9:30. So started with the first session, primary survey and adjunct by Dr. Varnika Kala, Associate Consultant, HN Reliance Hospital, Mumbai. Madam, it was an excellent session and you have highlighted how important is preparation and triaging of those patients. It was very simple and very good with multiple examples. So thank you very much for having conducted. So I request all of you to give her applause. Next is session 2, which is already done by Dr. Sajid Kumar P, Assistant Professor and Lead Faculty, Advanced Lab, Government College of Nursing, Kozhikode, Kerala, Secondary Survey and Adjuncts. Your session was really very simple, and I think all the newcomers, I think there are second year, third year students, you must have understood how important is the secondary survey. The primary survey is done within some minutes, within 5 minutes or 10 minutes, and then the secondary survey continues. So that is very important. So you have already done. Thank you very much, Dr. Sajid Kumar, for the wonderful session you have taken. Session 3 is triage by Dr. Bhakti Sarang, Professor, Department of Surgery, Prerna Medical College and Hospital, Navi Mumbai. We are just eager to listen to you, madam. Welcome for this session. Session 4, Predicting Difficult Airway Management by Dr. Ankita Joshi, Associate Professor, Department of Anesthesiology, MGM Medical College, Kamote, Navi Mumbai. So we are just eager to listen to you after the next session. Session 5 is Initial Management and Hemorrhagic Shock by Dr. Sanjay Doke, the HOD, Department of Dermatology, MGM Medical College, Kamote. So these are all sessions which will be before lunch, and then we will have lunch break from 12:30 to 1:30. After that, hands-on training. Workstations are arranged on the 6th floor of MGM Hospital, Kamote. That will be, the sessions will be from 1:30 to 4:30 p.m. 4 hands-on stations are there. Number 1 is Basic Airway Skills by Dr. Deepika Sate, Professor, Department of Anesthesiology, MGM Medical College, Kamote, Navi Mumbai. Yes, ma'am, the group will come to you. I think they are all very eager to listen to you and attend your session. Advanced Airway Management by Dr. Deepika Joshi. Interpretation of X-ray and CT scan by Dr. Sajid Kumar P. And application of tourniquet, traction, splint, pelvic binder, cervical collar by our own Mr. Jignesh Vyas, nurse practitioner. So these 4 sessions, skill stations are arranged in the hospital. You will be guided by our volunteers. Day 2, tomorrow it will start again at 9:30 to 12:30 sessions. Thoracic trauma by Dr. Nikhil Rane, thoracic surgeon, MGM Medical College, Kamote. Thermal injuries will be done by Dr. Sunil Keshwani, cosmetic surgeon, National Burn Center, Navi Mumbai. Tea break after that of 15 minutes, then session next on head trauma by Dr. Dikpal Singh Jadhav, Associate Professor, Department of Neurosurgery, MGM Medical College, Kamote. Session 9 is spine and spinal cord injury by Dr. Akash Sarjogi, joint replacement surgeon, HN Reliance Hospital, Malad, Mumbai. Session 10 will be done by Dr. Lieutenant General K.R. Salgotra, Hospital Director, MGM Hospital, Kamote, on management of multiple trauma. Session 11 on abdominal and pelvic injury by Dr. Lisha Suraj, Professor, Department of Surgery, MGM Medical College, Navi Mumbai. And 1:30 to 4 p.m. there will be poster and paper presentation. And after 4 to 4:30 is the valedictory session tomorrow. I hope all this meticulously planned sessions and coordinated by our own team will have fruitful results, and all of you will have great learning. Thank you very much.
Thank you, ma'am. Now may I request our Honorable Vice Chancellor, Sir, Dr. Shisham Dalvi, to deliver his address, and I request Dr. Prabha Dasilla, ma'am, to felicitate him with this happening.
So good morning to all. On this occasion of National Workshop on Emergency and Trauma Management by Nurse Practitioners, the organizing chairperson, Dr. Prabha Dasilla, organizing co-chairperson, Dr. Ponchitra, organizing secretary, Mrs. Nair, organizing co-secretary, Mrs. Jubilson, all the faculty members of MGM Medical College and Hospital, Kamote, Dr. Kamote sir, Dr. Mohanty sir, Dr. Bhusare sir, all the other faculty members from the various departments, the faculty members from the nursing, the external faculty members from the various states, Dr. Varnika Kale, Dr. Sujit Kumar have come from the different places to participate in this particular national workshop. As I have been told that nearly 255 participants are participating in this particular workshop, and large number of, in the unfolding of the theme, Madam have provided the various aspects of the workshop and academic dish that is being, you are enjoying within the 2 days, that consist of the various theory lectures by the eminent person, external experts, internal experts, who are working in this particular field, they will share their practical experiences that they are having. Also the hands-on experience, the skill lab. And the 4 sessions of the skill lab and the actual things that we will learn there. That is also one of the important component of this particular workshop. And also the paper and the poster presentation. So 2 days and the various types of the academic interactions that will occur and that will go for the long way. This MGM Medical College and Hospital Kamote, the unique feature of this particular one of the institute and all our colleges, this is located at such a place on the highway, national highway, where number of national highways are near the Kalamboli Bridge, those are coming together. And all the trauma cases, the injury cases, the accident cases occurring on these express highways, those are brought to the Mumbai. And as express, in case of trauma, the golden hour is the important, and the first point, the golden hour, is the Kamote that they get. And they are not going here and there because they are sure they will get the quality care. And the academic program should be need-based program. And our nursing college have rightly grabbed this particular opportunity of starting the academic program, which is really need-based program. The nurse practitioner program, the prestigious program of the nursing community in our country, to start that particular program at this particular campus. And also the emergency and trauma care management, because the quality is the sustenance. After starting the program, the healthcare is available, but the quality of the healthcare that also important. And to enhance the quality, to sustain the quality, such workshops will surely go a very long way. Even in other disciplines, surgery in trauma, MS surgery, everybody know, but MS in trauma, that is the first degree that has been launched at this medical college and hospital campus in the country. So the academic programs, which are need-based program, as per the community requirement, those are being delivered here.
मला म्हणते मॅडम मॅडम इकडून जाते सदाशिव गडला आणि कोण डोंगरावर चढली म्हणजे काय करता तो एरिया कसा आहे कुठे पण जातो आणि एवढं हे मला माहिती फक्त डोंगराच्या पायथ्याशी
Hello, hello. Hello, mic check. Hello, hello.
Currently, she is working as professor in Department of Surgery, Turner Medical College and Hospital, Navi Mumbai. We welcome you, ma'am. I request Mrs. Shivakama Sundari, Assistant Professor, MGM New Bombay College of Nursing, to felicitate her.
So a very good morning to all of you. I feel you're all refreshed after the tea. So you've already gone through the primary survey and the secondary survey. So I'll take you through triage. So triage is one thing I would say not doctors, but nurses are supposed to master because they are the ones who face the patient as the patient comes in the emergency room. And doctors should be learning from nurses how to do a triage. So I'll just quickly take you through it. As I see, we are already running a bit late, so I'll try and cover up some time. So triage. So what do you mean by triage exactly? So it's derived from the French word trier, meaning to sort or to choose. Means you have to pick the right patient. So patients are classified according to the type and urgency of the condition. So what is the rule in triage? So the rule is take the right patient to the right place at the right time and with the right care provider. It's the rule of right patient to the right place at the right time with the right care provider. So what is the triage process? I'll quickly take you through that. So as the patient comes in, we all face the patient and that is the initial contact with the patient. And as Dr. Sajid Kumar stressed that vitals, that is the first thing that all of us should do when we face a patient. So it is the reception and the initial contact with the patient. Then you quickly go through the primary assessment. I'll not go into the details of it. Then what you do is you have to assign a triage category to the patient based on how severe the injuries are. So this is one step which is very crucial and this is what we should be able to do. And then documentation and communication. So what happens is when we see the patients, we are so engrossed in managing the patients that we completely forget the relatives of the patient who are hanging in there and who want to know what's happening with the patient. And as both the speakers have already mentioned, there should be one team lead and there is a team. So there should also be one person who's from the team who's communicating with the patients. And communication is at various levels. You should be communicating with the relatives, but there is other communication that is needed. Suppose as a nurse, you are in the casualty with a resident doctor. But when you see the patient, you might feel that this patient needs better care, more care. So you know when to contact the senior faculty. So which is also very, very crucial out there. So communication, interprofessional collaboration, and definitely the handover process. These have a big place in triage. So moving on. So what is the triage assessment framework? You all know the A, B, C, D, E. So as the patient comes in, just imagine a patient coming into your emergency room. You're observing the patient, quickly see his airway. If he's not in a good state, open the airway, try and clear out the airway. Then quickly move on to the breathing. And all these things run in parallel. It cannot be one after the other. So there is a team lead who's directing members of the team to do one procedure each. So it is quickly the airway, then you assess the breathing, then you put 2 wide bore IV cannulae and start the circulation. Then you go on to the disability assessment, and it has to be with good exposure. So A, B, C, D, E, I wanted to, but I'll not go into the details because of time constraints. Then comes, and it has already been covered for you. Then comes the primary and secondary survey. So primary survey, as mentioned, is to identify and manage the immediately life-threatening conditions. And secondary survey, it's equally important, but slightly less important than the primary survey. You get some more time, less important as in you get some more time to do some thinking and do the actions. And triage and mass casualties is a different scenario. Now, what are mass casualties? Any natural disasters like earthquakes, floods, or say terrorist attacks or transportation accidents, wherein many patients come back to you in mass. So what are the triage categories? So this is what I would want you to focus upon. So it is very much color coded, like the color coded bags that we have for waste disposal. Say. So what are the triage categories? So first triage category is the red triage category. So the patients in red means you should be on high alert. So they have to be taken immediately. They need immediate treatment, and if not given to them, these patients may die. So immediate management for preservation of life. And what is the target time? Target time is not even 5 minutes. It has to be immediately. And that is the golden hour or diamond hour or platinum hour that Dr. Sajid Kumar mentioned. Then comes the second category, which is the orange category. This also includes patients who are seriously ill or injured, but for them you get slightly more time. Now you might feel what is the difference in category 1 and category 2? So a tension pneumothorax which comes to you, it has to be decompressed immediately. You don't have any time. So you put a needle there and decompress the thorax immediately, even before you put an ICD. And pneumothorax will come in the very urgent category, wherein you get some time. You will get that 10 minutes time to work on it. So that's the difference between category 1, which is the red category, and category 2, which is orange, which is equally urgent, but you get some time buying. Then comes the third category, which is the yellow. So it is the urgent category. This includes patients with serious problems, but they are in a stable condition. Now, stable condition means, again, vitals. Vitals are very crucial in trauma management. A simple pulse recording can tell you lots about the patient. And even if we become super specialists, we cannot forget the pulse of the patient. That is very, very, very crucial. So the yellow category, it includes patients with serious problems, but who are in a stable condition. And the target time for them is, say, around 60 minutes that you get. Then moving on is the green category. You can relax in these kind of patients who are not in immediate danger or severe stress. So again, target time, I'm specifically talking about the target time because it's very objective here. When things are very subjective, you don't know what to do. But when we have numbers out there, it becomes very objective. So remembering things becomes even more easier. So green triage patients, you get lot of time to see them, but you cannot ignore them. I'll tell you later why you cannot ignore them also. So you assign a green category to the patient and you have 2 hours to see the patient. But within that 2 hour span, you should be seeing the patients. You manage the red patients, but you have to also see the green patients at a later point. And finally, the blue category. This blue category, most literature, international literature just speaks about it, but there is no hard and fast assignment, but it's still out there. So these are the patients whose conditions are not two accidents or emergencies and can be treated by other healthcare professionals. So these don't really come into the trauma triage categories, and these can be managed by general practitioners or say dentists. So very less severe conditions, and target time is 3 or 4 or 5 hours or whatever the time may be. And finally, black is dead or moribund patients. So these are the patients once you label, you don't need to go back and relook at them. So I'll repeat the triage categories because that's what I'm here for. First is red immediately. Like the signals, when you see red, you stop, you relax. But it's exactly the opposite in trauma triage. You see red and you're quickly into action. So red is quick action. Orange is slightly less urgent. You get 10 minutes time. Yellow is a little less urgent. You get more time. You get say around 60 minutes. Then green triage patients, you can sit, relax, see the patient at leisure. And finally, black triage means the patient is dead. So moving on, what do you do after categories, after you have assigned a triage category to the patient? So emergency cases, the red, orange cases, you will manage immediately because they need immediate emergency care. So you see the patient, do the A, B, C, D, E, you get onto the secondary survey, you call for help. In case necessary, you call the senior faculty, you call some specific specialties for that particular patient, and you manage these patients. Then comes the priority cases. Priority cases are the cases assigned yellow. So they need assessment and of course rapid attention. But they can wait slightly for a longer time as compared to the red category, that is the emergency cases. And the non-urgent cases which have assigned the green category can wait their turn in the queue. So looks very straightforward, right? But you will see there is lot of data supporting this, that red triage patients, they are surviving really well. They are doing very well. But yellow triage patients are dying more. Is it counterintuitive? Ideally, the red triage patients should have more mortality than the yellow triage patients. But why are these yellow triage patients dying more? So they are dying more because we are so busy managing the red triage patients that we are not going back again to the yellow triage ones and re-looking at them. Their condition may be fast deteriorating, but we are missing that. So always remember, it's very, very, very important to revisit the priority cases. Emergency cases, everyone is interested in. We'll go do everything for them. But we should not forget the yellow triage category patients because they can also, there'll be no time from where they'll be converted to red triage. That category can upgrade to red triage. So always revisit the priority cases again after some time. So revisiting is very, very important in triage. You cannot just assign triage categories, place the patients there and not go back to the patient again, because as I will repeat again, we will see that the red category patients are doing really well, because we are focusing all our attention there. But the other categories, the yellows and greens, are dying because we are forgetting about them. So remember, red, orange, yellow, they need to be managed with utmost priority, and revisiting after triage is the rule. I'll be stressing on certain points because those will be your take home points after this class. So once you have tried, once you've settled the patient, you will have to do the documentation. Documentation is equally important because if you've done everything, but you've not documented what you've done, and later, especially in trauma cases, you'll never know when you have to stand in the court of law for that particular patient. So that time, what is going to help you is your documentation. So documentation has to be picture perfect. The way you have done here should be the thing that you have written on paper. So documentation mein first is the time and date of the triage assessment. It has to be the exact date and the exact time when you have first seen the patient. You might feel ये तो doctors का काम है. No, nurses, and I'm proud to say that all my nurses, their documentation is 1,000 times better than our doctors. So really claps to all the nurses, the kind of education that they have received, their documentation is picture perfect. And lot of times when I myself had to go back to for medical legal cases, I have seen the nurses' records than my residents or my records. So hats off to you all. Then comes the patient demographic information. Each and every demographic detail, name, age, sex has to be there on the paper. Then, of course, the chief complaint or reason for seeking care. In this case, particularly, it will be any kind of trauma that the patient has come in here for. Then vital signs, vital signs. I'm mentioning this because we have been working a lot on trauma registries in India, and we have seen that documentation of vital signs is missing in almost 40 to 50% of patients. Although you see, although you do, but you're not really documenting the respiratory rate, pulse is missing at times. At times, you're so busy managing the patients that you fail to do the vital sign evaluation. So that is very crucial, and your physical examination findings. Then comes the triage level assigned, the triage level that you have assigned, the triage level after revisiting the patient again, and the rationale for the decision. That is, why have you assigned that particular triage level to that patient? And then finally, what you need to document is the interventions that you've performed during the triage, if any interventions that you've performed. Now, very important is in why I'm stressing on the legal and ethical considerations also. These are equally important. While you're doing the clinical management, your practice has to be ethical and it has to remain in the legal framework. So, and you have to ensure fairness and impartiality in decision making. My neighbor has come, he's in a bad state, but he's in a green triad. But because he is my neighbor, I want to go and treat him before. So you'll run to your neighbor. No, there has to be impartiality in decision making without discrimination based on factors such as age, race, or socio-economic status of the patient. Then, second is, as the patient comes in, we are so busy managing the patients that we forget that there are 10 other patients sleeping, lying in the casualty with 10 other relatives of the patient. And we are stripping the patient off. What happens? The patient might not get up from there, but still we have to maintain the dignity of the patient. And we have to uphold the patient's privacy and confidentiality as required by law and based on our professional standards. Then, as I mentioned, communication, you would have seen there are a lot of many incidents where you find relatives coming in and bashing the doctors or relatives coming in and bashing the nurses. So do you feel it's always the fault of the relatives? It may be their fault, but we have to come back and reflect upon what we are doing. Patients, relatives, even when we are on the other side, when we are taking our patients to the hospital, we at least want the doctor or nurse to come in and tell us what is the status of the patient. Otherwise, we are going to be restless. We don't know whether my mother is going to survive that accident. So we have to be compassionate to the patient. And as a team lead, he should either go and talk to the relatives. While this management will go on. There are 10 people doing that management. But one person has to go and effectively communicate with patients and families. We cannot change what relatives are doing or patients are doing, but we can definitely change what we are doing. Our actions are in our hands. So let's change ourselves first before changing others. So communicating effectively with patients and families, providing very clear and simple explanations of your triage decisions and addressing the persons. Now, suppose my father is sitting there with a femur fracture, but there is another patient who has a very bad head injury. So the trauma team might be managing him. But then I want to know what is happening with my father. So one person has to go and tell the relatives that your father is stable. We will come back to him again, but we are managing another emergency patient. And this is especially important in mass casualties because managing this chaos is equally important, because if you're not going to manage that chaos, you're not going to manage this, be able to manage this. So that is very important. And finally, education and training. You cannot just do all the other things and not know your stuff. So we have to know our stuff pit pat. So maintaining competency in triage principles and techniques through ongoing education and training. So education cannot stop at one point. So today and tomorrow you're going to attend this workshop. So day after tomorrow you might feel abhi kuch bhi aane de main karta hu. No, it won't stop there, because when you actually go there and start managing the patients, you will know, oh, I don't know how this is done. Then you go back, read it, see online videos. There is a lot of knowledge sitting out there and really good knowledge. So try and look at the evidence-based platforms for knowledge. I'll mention a few things, few resources which are very useful resources and which are evidence-based resources which you can go back and refer. And always having in the US, I'll tell you the system is that all the residents, all the nurses, they carry small handbooks with them. You might feel, अरे उनको आता नहीं, हमने तो पढ़ा है. ऐसा नहीं है. What they do is, while they are managing the patient, now I manage a tension pneumothorax, I come back and read. Did I do it as per what is given in the book? Then you see what you have missed. So carrying these small handbooks is a very, very good idea, because then and there you can refer. Now we are in the era of technology, so you always have your mobile phones. You will remember the most if you've seen the patient now and read it now. Because now if you see the patient 10 days later, you would have forgotten half the things. So always, today you have managed the case, go back, read, see what you have missed. So next patient, your management will be slightly better. So education, focus on education and training is very, very important. Now, what are the challenges in triage? So MGM, it has everything, most of the things that need to be there. But you might know, you might be practicing in some peripheral areas where there may be resource limitations. So you will have to see what are the resources available with you and what are the things, what resources can you use, or where you will have to do certain manipulations or modifications in patient management. So if you that is a big challenge in triage, because if you don't have certain material available, you don't have manpower available, you are the team lead and you are the person who is managing. There is no manpower with you, but you might find yourself in such a situation also. So be prepared for such situation, and that is a big challenge in triage. Sitting here in MGM hospital, we might feel everything is there available with you, but that's not the case everywhere. Even in tertiary care setups, you'll find that there are some things which are missing. Then next challenge is ethical dilemmas. Now, a child has come to you. who is equally important? An elderly patient has come to you. Both are red triage patients. There are just two people with me. What do I do? Do I manage the child or do I manage the elderly? So you will find yourself in these kind of situations. I have had this, I'll just tell you a quick example. I was manning the trauma ward at Sion, and there was an elderly male patient who was on the ventilator. And as you know, there are hardly any ventilators available. And he's not really dead, but he may not survive. And a child comes in and who needs a ventilator now. So what do I do? Do I remove the elderly man from the ventilator? He's not dying. And do I put, my heart was saying no, removing him from the ventilator and put the child there. But it's not a very easy decision to make, I must tell you. Then there's lot of emotional stress. I'm sure we've all gone through it. All our first death, our first emergencies is very stressful to us. 10 days you cannot forget your first death. So it's very emotionally challenging. And especially when you are a triage nurse, it's very challenging because you're going to see really bad patients and they are going to die at some point in spite of all your efforts. So resource limitations, ethical dilemmas, and emotional stress are the challenges which triage nurses or doctors have to face. Now, I'll just take you quickly through diverse range of situations in triage, just for giving you an idea. I thought of making it a bit practical than just very theoretical. So, a natural disaster has struck in a remote area, severely damaging infrastructure and leaving many residents injured. The local hospital is overwhelmed with casualties, but supplies and medical personnel are limited. So what is the dilemma? The nurses must prioritize patients for treatment despite the scarcity of resources. So here you might be faced with ethical dilemmas. So what they should do, they should weigh factors such as severity of injuries, the likelihood of survival, and available resources to allocate the care effectively. So you, as I mentioned earlier, I'll not go into the details of this. So first situation is a limited resource setting. You have 10 patients out there and your resources and manpower are limited. So you have to prioritize patients based on the injury severity and then likelihood of survival. Second, again, a very similar scenario, mass casualties with diverse needs. So a terrorist attack which has children, women, pregnant females, adults, everyone together. So the dilemma is there'll be different kinds of injuries and different kinds of patient populations. So you have to ensure that you provide equitable. Equitable and equal are two very different things. So I don't know if you have equitable means there is a very poor man and there is a very rich man. So you have to get them to the same level. So you take the poor man up and take the rich man slightly low and balance it. So that is equity. It is not as comparable to equality. So I'll quickly rush through this. So you have to check again factors like age, vulnerability, and the severity of injuries. Third situation, critical patients, limited bed capacity. Similar to the example which I mentioned, there's an influenza outbreak, you have shortage in the ICU. So again, the more critically ill patients will need more attention. Then conflicting triage criteria. Conflicting is the one example that I explained. So again, nurses must reconcile conflicting triage criteria and make decisions based on the best available information. You might not know where should I place the patient, red or yellow. So what is better? So it's always better, if you are in doubt, always better to give a assign a higher triage category to the patient. You might feel that this patient is okay to be in yellow, but he might also be in red category. So it's no harm if you shift up to the red category and manage him more intensively than less intensively. So conflicting triage criteria, when you have conflicting decisions to make about which triage category to choose, assign the higher category. So this is the third take home, assign higher triage category if you have conflicts. And finally, language and cultural barriers. These are very frequently there because we do a lot of migration. So Keralites come to Maharashtra, Maharashtrians go to Bihar, and this way we are all moving around. So language and cultural barriers. So one message which I would want to give is try learning the local language wherever we are placed, because that makes your work a lot easier. Now, strategies for effective triage, as I mentioned earlier, training and education, then simulation exercises. Of course, you are going to have those in the workshops that you are having. And there has to be a continuous quality improvement. Every day, there has to be some new improvement that is coming. And the resources which I was talking about are the two very good resources, especially for trauma nurses. There are various courses held by AIMS Trauma Center, JPNATC, one of which is National Emergency Life Support Course, both for doctors and nurses. Because, see, it's like always I keep hearing this. Oh, I'm just a nurse. I don't need to do this. Oh, I'm just a nurse. This is not for me. It's not that. Doctors and nurses are equally important very much for trauma management, and they are at equal levels. So do not forget this. For saving the patient's life, a nurse is equally important. So this National Emergency Life Support course is designed in such a way that it includes the doctors, the nurses, the other paramedical support, and it even involves what we call the mama maushis, the assistants, attendants. Because what happens is, you might say, oh, take the patient quickly to CT. But he might know where the trolley is. He's a new mama who's joined in. He's a new assistant attendant who's joined in. He might not know where the trolley is, or he might not know where your CT department is. So these things are also very important in management. So it is a teamwork, and not only the team of doctors and nurses, but doctors, nurses, the paramedics, the blood bank person, the CSSD person, and the attendants as well. So we are all working at an equal level for managing that particular patient. And the other resource, which is also freely, these two resources are freely available online also. So the WHO Emergency Triage Assessment and Treatment course, which is very easily available. Now, most of the points which I wanted to make, I have made. So first point is to assign triage categories, assign a higher triage categories when you have conflicts, then revisit the priority patients, especially the yellow triage patients. And now I'll quickly want to show you a video.
Hey everyone, it's Sarah, registered nurse, RN.com, and in this lecture, we're going to talk about the color-coded tag system and the START method used in disaster triage. And as always, whenever you get done watching this YouTube video, you can access the free quiz that will test you on this content. So let's get started. The word triage means to group or rank. And in the healthcare system, we triage patients. For instance, in the ER, patients come to the ER seeking care, and they will be triaged, hence group or rank, based on what they're presenting with, their signs and symptoms. If they're really bad off, they will be seen immediately. However, if they don't really meet that criteria, their treatment will be delayed and the patient will have to wait a little bit until they are seen. However, in this lecture, what we're talking about is triage in a disaster situation. Because whenever you have a disaster, you have many wounded coming to you that needs treatment. However, you're very limited on your personnel and your resources to treat those people. So you have to use them very wisely. And that is where triage comes in handy, specifically the color code tag system, because it's going to tell us which patients should be seen first, and it tells us what type of injuries would fall into certain colors. So for exams, what you want to know is all these colors, there's 4 of them, a patient will fall into one of them, who's seen first or has highest priority, and what type of injuries you may see with each color. And we use that color code tag system, but we also use a tool to help us determine which color the person will be tagged. And that is called the STAR method. And we will be going over that here in a moment as well. So first, let's talk about the color coded tag system. There are 4 possible colors a patient could be tagged. We have red, yellow, green, or black. Now, to help you keep this information straight for exams, because some people get confused on red, yellow, and green, like who has highest priority, let's think of a traffic light. Because with black, that's easy to remember. The color black is associated with death, and these patients are dying or have died. So with a traffic light, most traffic lights have red, yellow, and green. So think about what you're supposed to do whenever you see each light color. So when we see a red on a traffic light, what does that mean? That means stop. And so these patients who are tagged red, they are considered immediate. They need immediate treatment right there. So they are seen first. They have highest priority. And the reason is because their injuries are life-threatening. However, they are survivable possibly if we can get them treatment right then and there. And these patients are going to have severe alteration in their breathing, their circulation, their neurostatus, mental status. So they're going to have some issues, but if of survival, or patients who have significant burns on their body. Circulation, mental / neurostatus is within normal range. However, eventually that is going to change because their injuries are serious. So termed as the walking wounded. So these patients can get up and they can go. So they are considered minor. They have very minimal injuries. These injuries are not life-threatening, and their breathing, circulation, neurostatus is not expected to really change. So we can delay their treatment for several hours. And sometimes these patients can actually treat themselves, so self-care. And then lastly, we have the tag color black. And black patients who are tagged this, we consider this expectant. So they are in the process of dying or they have expired, died. And their injuries are so deadly to the point that they're just not going to survive. So you have absence of that breathing, circulation, neuro / mental status. So now let's talk about the STAR method, which is used to help us assign a tag color to a wounded individual during a disaster situation. And the word STAR actually stands for simple triage and rapid treatment. And this particular STAR method that we're going over in this lecture is for the adult patient. It's very quick and easy to use. So the first thing what you want to do is you want to look at that wounded individual and you want to see what they're doing. Are they able to move, walk around, or are they unable to do that? If they are able to walk, that tells you right there that this patient's breathing, they have circulation, and they have a neuro system, mental status is there. So you're automatically going to tag that patient green. This will be the only time that a patient will be green. Now, the other part of this method is for patients who are unable to walk. And they're either going to be tagged red, yellow, or black. And you're going to be looking at 3 things in this particular order. You're going to be looking at their breathing, their circulation, and their neuro / mental status. So first, breathing. What you're going to be looking at is if they're breathing, and if so, what is the rate of breaths? So let's say yes, the person's breathing, but their respiratory rate is greater than 30. We know in an adult, a normal respiratory rate is about 12 to 20 breaths per minute. So if it's greater than 30, something is definitely going on with this person and they need immediate treatment fast because they are not doing it. So they are going to be tagged red. Let's say they are breathing, but the respiratory rate is less than 30. Well, we will proceed and check their circulation. Let's say they're not breathing. What you want to do is quickly reposition that airway and reassess if they're breathing. If they're not, they are going to be tagged black. So let's say, reposition that airway, they do start breathing, have spontaneous breaths. Well, this tells us this patient isn't doing good. They're only breathing because we reposition the airway, so they do need immediate treatment. So they're going to be tagged red. Now we're going to look at circulation. And what we're looking for is a positive radial pulse, or if they have a capillary refill less than 2 seconds. Those things really tell us our patient is perfusing, which is a good thing. So let's say, yes, they have this. We will proceed and check their neuro/mental status. If they don't have this tells us that something is wrong, so we will tag them red. Then lastly, we're going to look at their neuro/mental status. And what you're doing with this is you're seeing if they can obey or follow your commands. So let's say that, yes, they can do that. Well, we're going to tag them yellow. If they cannot do this, they would be tagged red. So let's quickly recap the START method. So a patient is only going to be tagged green with this method if they are up and able to walk around, because this tells us they're breathing, they're circulating, and they have a mental status neurosystem that is working. And that's for patients who are only walking. Now, patients who are unable to walk, they're either going to be red, yellow, or black. Now, they will be red if they have the following issues. They're breathing, but that respiratory rate is greater than 30. Or if they weren't breathing at first, you reposition their airway and all of a sudden they are breathing, they would be red. If they don't have a radial pulse or their capillary refill is greater than 2 seconds, they would be red. Or if they're unable to follow your commands. Now, patients only going to be tagged black. You check that breathing, they're not breathing when you reposition that airway. They would be tagged black. And they will only be tagged yellow if they're breathing, it's less than 30, if they do have circulation, and they can follow your commands whenever you're assessing their mental status. Okay, so that wraps up this.
So this was the START criteria, and you can make this kind of criteria for you: walking, breathing, circulation, and neurological assessment. And quickly start ticking. Checklists are very important in any kind of management. So now we are using the WHO surgical safety checklist. There is a trauma checklist, because when you see the checklist, you might have done 5 things, but you've forgotten 1 thing. So when you quickly see it, start ticking it, you will know, oh, I have missed this, I have to do this. So that is very important, and also a very important part of triage management. So with this, I would like to take a leave and thank you all. Thanks to everyone for inviting me here for this talk. And I hope you will be able to take back home some points at least from this. Thanks a lot.
Thank you, Dr. Bhakti Sarang, for the brief description of the different aspects that has to be considered in triaging with excellent scenarios and videos. Now I request Mrs. Shivakama Sundari, Assistant Professor, MGM New Bombay College of Nursing, to appreciate her with the certificate. Here I introduce the next resource person of the day, Dr. Ankita Joshi. She has completed her MD in anesthesia, fellowship in cardiac anesthesia. Her experience and clinical interest include transesophageal echocardiography, advanced hemodynamic monitoring. Her special interest areas include cardiac and regional anesthesia. She has organized various simulation workshops as transesophageal echocardiography, regional anesthesia, advanced airway and simulation. She is selected as regional faculty for American Heart Association from 2024 to 2026 for India region. She is a faculty for American College of Surgeons accredited Advanced Trauma Life Support course. She is also a faculty for Royal College of Surgeons accredited care of critically ill surgical patients course. Currently, she is working as an associate professor in Department of Anesthesiology, MJ Medical College Hospital, Navi Mumbai. We welcome you, ma'am. I request Ms. Preeti Banerjee, Assistant Professor, MGM New Bombay College of Nursing, to felicitate her.
A very good afternoon to everyone. Thank you for kind welcome. And I know you all have been inundated with a lot of knowledge since morning. We had some wonderful lectures by my seniors, my colleague Varnika. Moving forward, like Varnika said in the beginning, that airway is very important. Whenever we are talking about primary survey, initial assessment, first thing is A, right? What does A stand for? Airway. So is airway easy? Always. All of you might have had some experience in casualties, ICUs. Huh? So airways are easy or how? What's your experience? Difficult. So you never know. You never know when an airway could be difficult. So these are a few guidelines to understand what are the predictors, what are the ways in which you can predict that your airway is difficult. How do we move forward? All right. So in this lecture, we'll understand the normal anatomy and physiology of airway. We'll recognize a compromised airway. We'll try to determine factors leading to difficult airway. We'll know various predictors of difficult airway. We'll understand various aids to secure airway. And we'll have some idea as to how to manage unanticipated difficult airway. So basic anatomy, I think everyone knows it starts with your nose, nasal cavity, pharynx, larynx, trachea, then bronchi, bronchioles and alveoli. So alveoli is the primary unit where actual respiration and ventilation takes place, where there is gaseous exchange between oxygen and carbon dioxide. So we inhale, air fills in alveoli by our anatomical tract. Oxygen from alveoli goes into the bloodstream, it's picked up by hemoglobins in RBCs. It's carried to the various tissues, organs. There it's exchanged. Carbon dioxide comes in and via same tract, we exhale that air out. All right. This is how a normal physiology in a normal human being works. Then comes, let's see a case scenario. So the mechanism of injury, a 40-year-old obese restrained driver while driving on a highway lost control of his car and crashed driver's side into a tree. He had some abrasions on face, arm and chest. The patient was hostile during extrication. A spinal motion was restricted. He was restricted on a long spine board. A cervical collar was given and bag and mask ventilation was ongoing. This is somewhat a scene from the accident site. So can anyone tell me, like when this patient will come to you, you got this information over a phone call, In this scenario, is the airway okay or it may be compromised? How many for compromised? Everyone from that side thinks it's gonna be all right? Okay, so we have few people who think it can be compromised or threatened. Why? Obese, very good. Short neck, yeah, very good. What kind of accident it is? It's simple. Look at the car. The driver was on the driver's seat. Could have had blunt trauma to chest. He has some abrasions on his face, arm and chest. We don't know what's behind, like Sajid sir told you, what you're seeing. It's not just what you're seeing. It can be something concealed as well. So these are the few factors which may be leading to difficult airway, like the body weight, possible facial neck injuries, possible head injury because of the type of collision, possible intoxications. Is that a possibility here? Yeah, it can be a possibility. Medical comorbidities, 40-year-old, common age nowadays for hypertension, for any cardiac disease. He might be asthmatic, we don't know that. So considering all these things, considering all these points, when this patient will come to your casualty, you already have a scenario in your head that patient's airway might be threatened here. Okay. So what are the predictors of difficult airway? There's one thing called look and listen. What are you supposed to look at? Anyone from that side? You guys are quiet for some time now. What do you want to look at? The patient has come to casualty. Do you just blindly start doing everything or you look at the patient? Does he have any facial injuries? Is he looking all right? Is he bleeding from somewhere? Is he looking at you? Is he responding to you? You look at all those things. What do you listen? Exactly. Any added sound, any adventitious sound, whether or not my patient is talking. That's the first and foremost question that you should be asking. Patient comes to casualty, you ask simple questions. Hi, what's up? How are you feeling? He says, I am all right, but I'm having a lot of pain. What does that indicate? Exactly, the airway is patent. Because he's talking, he's able to phonate. That means that his airway is patent. Then pediatric patient. Airway is gonna be fine or how? Are kids easy in any way? Any which way? Are kids easy to handle? No. So when we are talking about adults and when we are talking about pediatrics, it's totally different thing. Pediatric patient आया फटाक से मान लेने का कि airway is gonna be difficult. Like howsoever expert you might be, just consider pediatric patients as difficult airway. Then there's a famous criteria called Lemon criteria. It's a mnemonic, stands for various things. L stands for look externally. We already discussed that part. We'll just once again look. In the first picture, yes, Ruksar, easy intubation, easy bag and mask. In the first picture with the red t-shirt. Why? Patient is obese. Yeah. In the second picture, yes. Facial trauma. In the third picture, Mr. Simpson. Easy. Somebody from the back benches. If that patient comes to you, are you going to consider his airway to be easy? Why? Short neck, maybe. What else? What other prominent feature in Mr. Simpson? Huh? What is that? So he has buck teeth. So if you have very protruding teeth, it becomes difficult for the person at head end to manage airway. Fourth picture. Exactly, large tongue. All right. What's wrong with Dumbledore? Huh? What's wrong with him? Old age, yeah, maybe. Anything else? He has a long beard. So if I have to bag and mask this, I won't be able to even find the chin bone. So with beard in picture, it becomes difficult. That's why when you have patients posted for elective surgeries under general anesthesia, there is one instruction to shave off mustache and beard. That's the reason. Okay, so moving forward, E stands for evaluate. There is 3 and 2 ratio. When a patient comes to you and if his inter-incisor distance is approximately 3 fingers, try everyone. Is it 3 fingers, more than 3 fingers, or less? More than 3? Anyone with less than 3 fingers? Nobody? So all of us have safe airways. All right. Then the next comes mentum to hyoid. The distance again has to be at least 3 fingers. And then comes between, you're not able to see it. Okay. Then comes between the thyroid cartilage and the mentum. The distance has to be at least 2 fingers. All right. So when the patient comes and if that patient is providing you time to evaluate these things, then you can see whether the distance between upper incisor and lower incisor are 3 fingers. This distance is 3 and this distance is approximately 2 fingers. If all of these things are in this ratio, then there might not be difficulty in securing airway. Then comes famous Malampatti classification. I think you might have gone through it various times. You ask patient to open his mouth wide. Class 1, you are able to visualize all the structures. You are able to visualize the soft palate. Class 2, you are able to visualize the uvula completely. Class 3, you are only able to visualize the base of uvula. Class 4, you are able to just see the hard palate. All right, which one is difficult in this? Class 1 or 4? 4. So if your patient has class 4, that means he has a very restricted mouth opening and laryngoscopy could be difficult in such patients. Then O stands for obstruction. Various kinds of obstruction like foreign body in the nose, foreign body in the mouth, facial trauma, peritonsillar abscess, epiglottitis. Neck mobility, restricted neck mobility, like in some medical conditions like ankylosing spondylitis, rheumatoid arthritis, cervical spine fracture, patient already has a C collar, it is gonna make your job harder. So all these criteria combined, if they are not matching the given criteria, they can cause obstruction of the airway, which will make your laryngoscopy and ventilation difficult. So these are various aids to secure airway. I'm sure you might have seen in your crash cars or in the trolleys in emergency departments and everywhere. The first one, multicolor ones, are your, what are they? Toys. So they are airways, oropharyngeal airways. They come in various sizes. You have to check the size of the airway. Insert the airway in a proper manner, which will be taught to you further in the skills station. Second is your nasopharyngeal airway. Nasopharyngeal airways can be used in all kinds of patients except for the ones who are having nasal bone fractures or base of skull fracture. Oropharyngeal airways, you have to be specific in which kind of patients you are using it. It's a hard material. You're putting it inside the mouth. What can it cause? Gag reflex. It can initiate gag reflex. So oropharyngeal airways, we specifically put in patients who are unconscious, while nasopharyngeal airways or NPAs can be put in all kinds of patients except for nasal bone and skull of base fracture. Then other aids include your supraglottic airway devices. They are of various kinds from ProSeal to iGels. We'll be seeing it again in the stations. Supraglottic airway device, as the name suggests, it lies above the glottic opening. It doesn't enter the trachea. It doesn't require a lot of skills to insert supraglottic airway device. You don't have to do laryngoscopy for that. You just open the mouth wide, take the appropriate size. The size is weight dependent of supraglottic airway devices. You put it in, you inflate the cuff seal makes a seal, you attach it to the oxygen enriched source and you're good to go. Okay, that's the placement, how it looks when it's placed. Then comes your bag and mask ventilation, another very important step, because as much as you like or are fascinated with intubation, it's not an emergency. Bag and mask ventilation helps in oxygenation, which is the critical treatment decision which you are supposed to take in a case of emergency. All right. Bag and mask ventilation, as the last picture depicts, you have to form that EC clamp. Your 3 fingers make the E. You lift the chin with that. You have those 3 fingers on the jaw. With the C, you are putting the mask on the patient's face. That's how you make the EC clamp and secure the oxygenation of the patient. Then there are few devices which helps in intubation. The first one is bougie. Second one is stellate. Both of them help in intubation. Stellate is a hard material you put inside the endotracheal tube. Why do you put that? Because the tubes are floppy. They are flexible. When you put stellate, it takes the shape of stellate. You can bend the stellate from the ahead part of the tube. You can put the tube via stellate and bougie. If you have anterior vocal cords in some patients, if you are able to just see the chunk of vocal cords, then in those cases, you can first put the bougie and railroad endotracheal tube on that bougie. Okay. Then the picture here on the right corner is a picture of video laryngoscope. It's now, I think, available in our ICUs as well. So video laryngoscope is a type of indirect laryngoscopy in which you are putting the scope in and whatever the camera is capturing, it's depicting on a screen outside. All right. So it's a kind of indirect laryngoscopy. It's a very helpful measure in difficult airways. Then comes burp maneuver. I'm sure everyone must have given this maneuver at some point when the person who's intubating might have told you to give pressure. So that pressure is backwards, upwards, and rightwards pressure that you do for the external manipulation of the vocal cords. You manipulate from outside as per the instructions given to you by the person who's at the head end. Okay. Lastly, you have fiber optic intubation. Fiber optic intubation is not a thing that can be done in an emergency situation. For fiber optic, you have to have the airway prepared. You have to anesthetize it with local anesthetic agents. You have to give transtracheal block. You have to give some sedation to the patient. You have to have fiber optic bronchoscope in your casualties with a TV attached. So what do you do? Basically, it's a very, as the name suggests, it has a fiber optic. You put it via nose or via mouth into the cords and you railroad the tube after this. This kind of intubation or scopies you do in patients who have very, very, very limited restricted mouth opening, like in patients who have carcinoma of buccal mucosa, carcinoma of tongue, very vascular bleeding sites in the mouth that you cannot touch it. In such patients, you go for fiber optic bronchoscope. I'm going to show you a video here. Okay, so they are not able to play the video, but I think that's the end part of the video. Just put it on the slideshow. So this is how your normal scopy in an easy airway patient looks. You are able to see the epiglottis which is hanging from above. You are able to see the whitish ivorish structure which is your vocal cords. After intubation, you see something like this. You can directly put the tube in. Okay. However, the second part, see the epiglottis. You're just able to see the posterior part of the vocal cords. Okay. There is some kind of swelling at the beginning of your trachea. It's causing very comprised structure. It's very compressed, small opening. You can just see the small opening. In such situation, you can always use a bougie to first insert the bougie and then railroad the endotracheal tube via it. All right, these were the videos. I think due to some technical glitch, we are not able to play, but this was the crux. Okay, everyone's here with me till now? Okay. So overview of difficult airway. All intubation attempts should be considered potential difficult airways. At no matter what stage you are in your life, you should be excessively confident about that you will be able to intubate any kind of patient. You will be able to secure any kind of airway. You should always have that at the back of your mind, what plan you have to have if you're not able to do so. Okay? Then the difficult airway algorithms are useful for considering all the contingencies that may occur during intubation. It may happen that everything is looking fine. You are able to, your all criteria are being matched, everything's looking fine, patient is fine. But when you are actually doing scopy and when you're actually trying to intubate, you're not able to do that. Okay? All team members must be aware of all the contingency plans. It's not just that you should know, you should have your team members on the same page. You should let them know what's going to be the next thing if you're not able to intubate. Algorithms involve a stepwise approach using different techniques for difficult intubation and difficult ventilation. We have various algorithms as to how to proceed when there is a difficult airway. In cases of unanticipated difficult intubation, like these, what were the predictors of difficult airway? Like via this, you can predict that in such and such patient, your airway is gonna be difficult. But like I just said, in some patients, you might encounter unanticipated difficulty. In those scenarios, you will begin with how we usually do. We'll pre-oxygenate, we'll have a checklist, we'll note the time. Why the time is important? When we are doing any airway procedure, why the time is important? Why? Loudly. Yeah, exactly. So the time that you're doing any maneuver, you're doing any procedure, your patient is in apnea. All right, so that apnea time is important. All right, so you note the time. Will pre-oxygenate. You can use various things to pre-oxygenate like face mask, CPAP, NIV, nasal prongs. Position, if you can give head up, that's going to be a good position. We'll assess airway, identify cricothyroid membrane. Why do you want to identify cricothyroid membrane? If you're not able to go via mouth, you might need to access via the front of the neck. Waveform capnography, as in the previous lecture, it was told that EtCO2 is very important parameter. You should have a monitor attached, a multi-para monitor with the EtCO2 graphing. We'll optimize cardiovascular system. Can we leave circulation part if we are taking time in securing airway? Can we let patients BP to drop drastically while we are managing? No. Will it be beneficial to secure airway if CVS is all down? No. So it's a horizontal way that you have to have everything in place. We'll share plan of failure. Plan A is tracheal intubation. How many attempts can we give for tracheal intubation? So what does it happen here? First junior attempts, then he calls his JR2, then he attempts, then comes JR3, then they attempt. But by the book, we cannot try so many times. Maximum attempts that we can give to an adult patient is 3 attempts. Maximum is 3. 3 तो अपना JR1 ही कर लेता है. So maximum attempt is 3. In OBGY patient and pediatric patient, maximum attempt is 2 because they have less FRC. We cannot have lot of apnea time for them. So they have only 2 attempts. If still you are after 3 attempts, you are not able to secure, what will you do? What was that one device which was easy to put without anything? Laryngeal mask airway, the supraglottic airway devices. I tried putting supraglottic airway devices, still I'm not able to do that. Now what? Still I'm not able to ventilate the patient. Then what? I think trauma JR, she's actively participating in the conversation. She might have a lot of experience in this. So I'm not able to put endotracheal tube. I'm not able to put supraglottic airway device. Now what? She's already doing that. What is that? I tried bag and mask ventilation. Still, I'm not able to do anything. I'm not able to ventilate the patient. I'm not able to provide any kind of oxygenation. Now what? Loudly? Yeah, somebody has done her homework. She's saying needle cricothyroidectomy. What is that? So you go for a front of neck airway approach. Okay, it's a skillful procedure. Like I teach that in ATLS. One of the faculties in one of the stations we have that. But tomorrow, if I have to actually do, my hands are gonna shake because it requires that kind of skills. So that's the last resort that you can go for a needle cricothyroidectomy or followed by surgical crico, or if you have an expert who can do percute tracheostomy. If you have a surgeon standby, you can always call them to do percutaneous tracheostomy. Needle cricothyroidectomy is a bridge between the definitive procedures and the failure of oxygenation ventilation. Okay, so in nutshell, the points to remember, like I'm saying, there is no such thing as an easy airway. All airways are supposed to be taken as difficult airway. By definition, all patients requiring urgent intubation. That patient has come to casualty, we are taking the trolley and everyone's dropping some things here and there and securing the airway. They are always gonna be difficult. Every case needs to be approached with the same level of sophistication and rigor. Every time you have to have a backup plan. If this fails this, if this fails that, every time you have to have that notion. Attributes of ER staff, first foremost thing, rapid assessment skills. As quickly as you will respond, as quickly as your mind will go to the place that it's going to be difficult, you are halfway near to the success. Preparation, you have to prepare your casualty, you have to have all the equipments. Technical proficiency, you should know where to attach what, you should know how to attach circuits. Is the oxygen machine, rich source working? Is your suction working? Suction, I think it's a universal problem everywhere. Whenever we want, it stops working. Every time answer is, till now it was working, right? Okay, the team communication, like it's a key thing in everything, not just airway. Every time team communication, constructive communication, closed loop communication is very important. You have to be calm under pressure. Okay, you can't shout on your juniors because you are panicking. You have to be very calm, and you should have the ability to troubleshoot. You should have ability to anticipate trouble. Am I clear? Okay, any questions? All clear or all clear? All right, to summarize, oxygenation is an essential component of our management. There are various indications depicting threatened airway. Correct recognition of these indications and timely securing airway is critical for improved outcomes. Decision of which mode of oxygenation is needed is based on the requirement. Saturation and EtCO2 monitoring should be mandatory whenever you can. Saturation in all patients, EtCO2 in patients with advanced airways. reassessment, like I think ma'am told that every time you have to go to the same place and reassess. Reassessment at regular places is very, very important. Thank you.
Thank you, Dr. Ankita Joshi. She is our own in-house faculty, and whenever we approach her for any workshops or workstations, there is never a no from her side. She's always ready to collaborate with the Department of Nursing. So we are happy that she is here with us today and has shared her knowledge on predicting difficult airways. So thank you once again. And I request Ms. Preeti Banerjee, Assistant Professor, MGM New Bombay College of Nursing, to appreciate her with a certificate. Next eminent personality we have with us today for our next section is Dr. Sanjay Roke. He's Head of Traumatology and Surgery at MGM Medical College, Kamote. He has completed Advanced Trauma Life Support under American College of Surgeons. He's also a certified faculty from Royal College of Surgeons for CHRIST. He's also a faculty for Basic Surgical Course of Royal College of Surgeons, UK. Currently, he is HOD, Department of Traumatology, MGM Medical College Hospital, Navi Mumbai. We welcome you, sir. I request Dr. Ponchitra, Professor and Vice Principal, MGM New Bombay College of Nursing, to felicitate him.
Good afternoon, everybody. Am I audible? Next. Okay. So we are going to divide this talk. Yeah, we are going to divide this talk. In the first 5 minutes, we're going to have some fun. How many of you are ready to have some fun? Fantastic. Next 20 minutes, we will do the job. And last 5 minutes, I'll try to show you some video. How many people went to school and colleges and were taught what to learn? Yeah. Okay. You want me to be stationed here? Thank you. So many times in school and colleges, they all tell us what to learn. But very few of us know how to learn. So there's a new technology or new science which is developing, which is called as meta-learning. Okay? Which is the most powerful thing that you carry around with you between your 2 ears, all throughout the day, which disturbs you and which also allows you to focus, right? That is called the brain, right? So I want everybody to just look at the slide which says, most important thing, how many people would love to learn faster? Right? How many people would like to really be really focused? But what we are doing today is we are in the age of digital distractions. Many of us are on our mobiles. every 11 seconds we are having some decisions to make. And we think multitasking is going to be better. We try to do 3-4 things at a time, right? So first thing I want to tell you, that your brain is the most powerful thing on this planet. What does it require? Brain has only 2% of your body weight, but it consumes 20% of your energy. And that is the reason that we have to give it a lot of oxygen, right? So can everybody stand up and take a deep breath. We are going to give oxygen to the brain. Deep breath, and slowly release it. Very slowly. Very slowly. Again, once more. Deep breath. Slowly release it. And second thing is you can have your water break, because the brain is, body is only 60% water, but the brain is 80% water. So whenever, even if you are 20% dehydration, you will get mental fog. And that is the reason that you get disturbed. You try to nudge your friend or think about your WhatsApp or your Instagram or how many likes you have got, right? This brain needs single tasking, right? So here I have got a mnemonic which is be fast. Third thing what the brain requires is glucose and ketones. So 50% glucose and 50% ketones. So that is the reason whenever you take good sugary breakfast, you are very high for some time. But after 45 minutes to 1 hour, you slump, you want to sleep or you want to doze off. That is because it's a temporary high. The ketones will give you a higher thing. The fat that you eat will give you satiety as well as this. So just coming back to this, you all can sit down now. I'll make you stand up again. Be fast is the mnemonic, where you can learn very fast. B is your belief, right? You know, everybody must know that small story which says the elephants, when they are small, the Kerala, there are elephants which they tie them to a small rope. They have a belief, they try a lot of things to break that thing, but they cannot break it. 10 times, 20 times, 30 times they try, they cannot break it. And they get a belief that they will not be able to break it. So when they grow up in life, even when they are huge and adults, they are tied with the same rope. Because the belief is they cannot break it. So whatever belief you have, as Henry Ford said, whatever thing you think you are right. If you can, you can. If you can't, you can't. So your learning is decided by your belief. So I want you to break all that belief. That the human brain is very powerful. It can really, and many times we have this notion that somebody says, I have a good memory, I have a bad memory. But there's nothing like a good and bad memory. There's only a trained memory and an untrained memory. So the problem is, are you willing to get trained? So this will help you. E is exercise. Okay? When you move, your brain grows. So can you just stand up again? And now just raise your hands high up to the ceiling, right? Stretch yourself. Now you can put them down. Now, two more minutes, you close your eyes and imagine that whatever hand you had raised, you are raising more 25%. Now imagine more 50%. Now imagine you have doubled it. And now you have raised it 3 times higher. Okay? Now can you open your eyes? And now do the same exercise again by raising your hands again. Raise as much high as you can. Put it down. how many people feel the second time you did it better? So where was the limitation? The limitation was in our mind. So the more we expand our thinking, the more we can achieve. So this brain is very powerful. You may have your seat. So first thing I'll tell you now, forget everything that you know about hemorrhagic shock, which I'm going to talk about. Why? I want you to be as curious as a child, as though you're learning something new. Right? So when you forget things, you become more curious. So your limiting belief system you have to break, and second is the distractions. How many people feel if your mobile becomes dead and the battery is not there for next 20 minutes, you can focus better? Yes? So next 20 minutes, keep your phones aside. Attention. I want you to make a note of this. Wherever your attention goes, you can focus. So make 2 columns on the page to take notes. How you take notes is a different technique. One side you will consume notes and the other side you will create notes. The difference is only subtle. Create notes is you're going to ask 3 questions. How I am going to use this? Why must I use this? And when I should use it? These 3 questions will make you learn better. Right? So whatever I'm going to talk, you're going to ask yourself, how I can use this, when I'm going to use it, and why I must use this. So if these 3 questions you can answer yourself on any topic, it will really make sense for you. And as I said, state. It is state dependent. Your learning is state dependent. What happens if you slump in a chair and start reading the book? Many people read books as a sedative, the last thing in the night, to keep or to go to sleep, right? But the same thing, if you're very focused and excited, right? Just I'll tell you an example of this thing. When you go on a picnic, early morning to late night, whatever activity you do, and if you want to recollect that in the night, is it easier or on a regular day it is easier? On the day of the picnic, it is very easy because you are all excited all throughout the day. And you will not forget anything on that day because the state of your mind is different. So that state of the mind is one. And T is teach. Learn with the intention to teach somebody. Then you will learn it much better. So we're going to do that. We're going to do that exercise and you will be coming. Third is enter. Enter is schedule it in your calendar. When are you going to teach and to whom are you going to teach? Right? So you may write the name of your best friend, your colleague, junior, your relative or a teacher. You should have a buddy or a study buddy whom you can educate. And this is your learn, earn and teach. Right? So you're going to learn, you will earn from what you are doing, and then you're going to teach. Teaching is your moral responsibility for the next generation. And with that intention, you will learn better. And review is until you review with repetition, things don't register. Right? So now be fast or be faster. These are the techniques which you can get from a book called as Limitless from Jim Quick. So he talks about all these things, and this is how you can make learning easier and more fun. Okay, let's go to the next. So as nurses, nurse practitioners, you are the most important part of a team. And first you become observing, you become a team player, and then you lead the team, and then you create other teams. So for that, for anything, you need these 5 Ps, right? Prior, proper planning prevents poor performance. So that's the reason that whether it is airway, whether it is breathing or circulation, you should see that everything is ready. Anybody has noticed any difference on this? Purposely the slide was put because there are 6 Ps and I have said 5 Ps. So that was just to check whether you're really focused or where's your attention. So what are the questions that you need to answer when you study a certain, and especially trauma? How can I be of help? How can I support? How can I assist or contribute to efficient management of hemorrhagic shock? So you, as I said, you become a team player and you are an important part of the team player. As they mentioned that it has to be a team effort. A surgeon cannot save anything independently. He is just the captain of the ship, but the team has to be efficient, right? He is ready to take all the blames, but he is ready to teach his team to be one of the best, right? So this is something that you are, what are the 3 questions you need to ask? You need to ask yourself, how can I identify the shock? What is the confusion? Where is my confusion? Where is the clarity? Okay? How do I classify the shock? Because there are 4 or 5 different types of shock. So I have to know what is an hemorrhagic shock and how do I treat? And the last is how do I manage this shock? So we are going to follow all that we are doing is following the ATLS protocol or ATLS. Here, American College of Surgeons have provided guidelines. These are some of the courses which you can do it over here. I think ATLS for nurses and pre-hospital care is not yet started, but I think that is a good thing to start off, and then we can train the ATLS nurses to be certified as ATLS this thing. We have an entire trauma team which is ATLS certified. So similarly, if the nurses are also certified, it becomes a great team to work with. And then the pre-hospital or the first responder, if they are ATLS trained, they can go to the community and we can prevent trauma happening right at the root level by educating people. So in your questions, it should be, why do I need to do it? How will it help in my career? And when do I do it? Right? So the 2 parts, primary survey and secondary survey. As everybody over here was saying, it has to be airway. It has to be breathing. Airway with C-spine stabilization, breathing and ventilation. And when it comes to circulation, it is with hemorrhage control. When you see blood anywhere, that dictum which will come to is control the blood and refill it. The disability and exposure, and the secondary survey is about the ample history. This is just for the allergic history. If he has any medications, if the patient is on, if there is any pregnancy, the last meal that the patient had, or the event, and the head to toe assessment. In between, there is an adjunct, primary adjunct and a secondary adjunct, which you can know. Now, what happens? As I said, brain is an organ which will have only give you 3 to 4 minutes. If the supply to the brain is reduced for 3 to 4 minutes, right? You can get into confusion, coma, and the heart will give you some time. The cardiac muscle dies after 6 hours. That is what they found out. The kidney will give some more time, 24 hours. So what we need to do is so how the body does is, body will try to divert all the blood to these 3 organs. So the first thing that will happen is the cutaneous supply will be shrink. There will be vasoconstriction. The muscles will divert the flow, as well as the visceral. The other organs like the GI tract or the splanchnic flow, that will have a vascular resistance, and then it will divert this thing. So the 4 classic hemorrhage are the different types. It is a progressive thing. It is not one thing. I don't know which one I'm dealing with. In the books, yes, it's very good to see the table, class 1, class 2, class 3, class 4. and then I draw the table, I draw the diagram, it's very good. But when it actually comes, there is a confusion. I have to put my clinical symptoms or clinical signs and then decide whether it's going into class 1, class 2, class 3 or class 4. For that, I have tried to make it easier. One is a hemorrhagic shock. Hemorrhagic shock is you see blood somewhere, blood everywhere. So you know that it has to be, but there'll be some places where the blood is concealed. You will not see the blood, but still the patient will be in shock. And those places will be chest trauma, will be abdominal trauma. It could be in the thighs or in the pelvic fracture or the retroped. So these 4 areas, I don't see the blood anywhere, but it is have to be one of the shocks. The non-hemorrhagic shock is cardiogenic shock. There is a pump failure. The heart itself does not function well. It could be due to MI in old people. It could be obstructive. Obstructive one, or what is called sometimes called restrictive shock, where the tension pneumothorax may kill the patient within minutes, or the cardiac tamponade. So this is where the breathing part, the airway, what we just now saw, how to maintain a airway, patency of the airway. The second one is how to maintain the breathing. So these 2 things, the tension pneumothorax and cardiac tamponade. And when my shock patient does not respond to IV fluids or blood, either I have to change my diagnosis, that is, am I dealing with neurogenic shock, or I have to see to it that there may be need more surgical intervention, aggressive intervention, or an IVR, intravascular angiographic management. So these are the 2 things that you need to differentiate. Class 4 is the extreme one, and class 1. It's very simple. Class 1 is how many people have donated blood? Can you just stand up? All people who have donated blood. Can you just stand up? Stand up. Give them a big hand. You can sit down. You all were in class 1 shock during that time. Right? Less than 750 ml. Usually they take 350 or 400 ml. Right? Only slight anxiety you must be having. You never had tachycardia with that. You didn't have a blood pressure drop that time. And whatever somebody fainted was because of the vasovagal attack. They didn't faint because there was loss of volume. Right? So that was class 1. Class 4 is something, it is pre-terminal shock. It's very aggressive treatment required, and many times you cannot save these people. So this pre-terminal is more than 40% blood loss is there. 40% of the blood volume. So it's more than 2 liters. Pulse rate is more than 150 and the respiratory rate is 35 to 40. And the blood pressure and the pulse pressure are reduced. Now, class 2 and class 3, there is the confusion. Class 2 is uncomplicated. Means many times we wait for the blood pressure to drop to call it a shock. But when the blood pressure drops, already 30% blood volume is already lost. So what is an early sign is your tachycardia is the early sign. So any patient with tachycardia or any patient with cold clammy skin and in casualty, always assume it is because of hemorrhagic shock to be on the safer side. So tachycardia and the respiratory rate, these are the 2 things that you look for. So this you can get in any book, and there will in class 3 there is confusion. So drop is more than 30% of blood volume. So how do you manage? First and foremost, as a surgeon, stop bleeding anywhere. So the first dictum is pressure, pack and wait. Pressure, pack and wait. So pressure, pack and wait. How? If it's in the limbs, it's a tourniquet. The tourniquet and this is the blood on the floor and 4 more. That's what we said. The chest may have fractured ribs and you may have a hemothorax, or you may have a massive hemothorax. More than 1,500 ml or 2,000 ml blood in the chest is called as massive hemothorax. Many times you will not get a pure pneumothorax in trauma patient. You will get a hemopneumothorax only, because it is always the blood along with the air. Only air, that means it's most probably a medical case where the bullae are broken or there's a lung contusion only without hemorrhage. So chest, abdomen, pelvis, and the thighs. The thighs, because the fracture femur is the most important thing, where more than 1,500 ml of blood may be there in that thigh itself. So how do you refill? Anything which is lost needs to be refilled. So the first dictum is 2 IV bore lines on the peripheral. If you can get it, then the central venous line can be avoided. But if you are not getting a peripheral line, a central venous line is a must. Venous cut down. Venous cut down, the easiest one is the one on the medial malleolus. Just palpate the medial malleolus on this thing, and the vein which is very constant there, you can just loop it up and push in fluids. Below 6 years of age and all ages, there's one more way that you can do is intraosseous needle, which is put in the tibia. We don't do it regularly here, but intraosseous needle is the fastest way to put in fluids and massive amount of fluids, especially in children, where you cannot get an IV line. An IV line cannot be got very fast, and you need a lot of skills to put it in children. But an intraosseous needle can be put inside and you can push fluids. So as you said, pressure, pack and weight on the limb, single bone. How do you tie a tourniquet? Usually it is on the single bone and proximal to the injury. And the pressure should be above the systolic blood pressure to really stop that arterial flow. And a pelvic binder. In case of pelvic fractures, a pelvic binder really can save. And if you don't have a pelvic binder, you can even put a bed sheet. You can roll a bed sheet and put it all around. Surgical intervention like an ICD insertion, exploration for hemoperitoneum if the fast scan is positive and the blood pressure is dropping, do not wait for a CCT or other investigations. Whenever in doubt, open the patient. 2 commonest injuries which happen are splenic injury who can bleed to death or the hepatic injury. The liver or the spleen, they are the solid organs which can bleed and they can have a torrential bleed inside. So do not conserve these patients if you don't have enough backup. The backup is you need a 24-hour OT available in case if you are going to conserve the patient, and you need 24-hour CT scan available to guide you whether you are to conserve this patient. So grade 1 and grade 2 in MGM usually we conserve, but a shattered spleen and the other hepatic and hemoperitoneum you have to operate. Angiographic embolization, vascular embolization. Now they have a hybrid OT in majority of places where the radiologist and the surgeon sit together and then they can just embolize the vein or the artery and stop the bleeding. So this hybrid OT concept is coming in very fast. So explorations are avoided. So what fluid to give? These are some of the questions that you may have to ask. 1 liter of crystalloids within 1 to 2 hours. And if you have blood available, what is the easy? Majority of the hospital, the blood that is required to be replaced usually takes 1 hour. In some hospitals, it takes 30 minutes. But if you have a type specific blood, that is the best. If you don't have type specific blood and really you want to infuse faster, it is the ORH negative. Why ORH negative? Because it does not have any antibodies. So antigen, so it will not produce any antibodies. So ORH negative can be given instantaneously. without cross matching. But ORH negative, many times the blood banks itself do not have it. Right? So what they do is, my daughter, younger daughter is ORH negative. Yes. So these are universal donors. And their blood is kept reserved, and they usually, when they go to blood bank also, they are told, we keep your number. Whenever we require, we call you and then we can bleed you. Right? So ORH negative is some unique blood who are universal donors of blood. So in massive transfusion protocol, more than when 10 units are required, there is a more chances that you may have to, they may go into coagulopathy and a DIC. So these things you should need to be aware. 1:1:1. That is 1 packed cells, 1 fresh frozen plasma, and 1 platelet. This is given if you are not responding. So how do you know whether your patient is responding or not? The tachycardia comes down. The pulse pressure is maintained. And the capillary refill time. What you saw, that cutaneous blood supply will be restored again. And the blood pressure comes up. The urine output, ABG and CVP monitoring. All these are required to tell you. As we saw, you have to find a trend. It is not a one-time thing. So you have to repeatedly assess the patient so that you know the trend. If the trend is recovering, they are responders. If they are not responders, you have to go in for surgical intervention is required, or your diagnosis needs to be changed. Patient improves with 1 liter of warm crystalloids, they will be called as rapid responders. Here, nothing may have to be done. But some cases, there will be initial responders and then they will deteriorate again. That is the reason that they say every half an hour, 45 minutes, you have to revisit your patients and try to monitor and chart out whether they are improving, deteriorating, or they need surgical intervention. So non-responders, ongoing bleeding is not controlled, or think of other causes of shock like neurogenic shock. So what are the unique situation? Innova had accident and there was a child in it, there was a grandfather in it, there was a pregnant lady in it, there was an adult. So the grandfather had a pacemaker. Yes, the driver who was an athlete used to go to the gym. So all these people have some unique considerations. If it's advanced age, that means the cardiac compliance and the pulmonary compliance is poor. So you have to look at that, whether they are on medications, whether a pacemaker has been put. So all your parameters that you're going to monitor, which is going to decide the type of shock that he's going to, will change. Athletics. People who do gym, people who go for running or running marathons, they develop very good cardiac output. Their cardiac output is 6 times more than the normal people. And the heart pumps very strong. And their blood volume is 15 to 20 times more. So what happens is, they have to pump very little. So their pulse rate is 45, 50, or less than 60. Where in a normal person, you would say that this is bradycardia. But for him, 50 is good enough. The heart is so strong, muscle is so strong that it's pumping, and it is pumping less. So that is the reason exercise is something that helps them to tide over this crisis. In pregnant ladies, the fetal circulation is compromised. So they have a very narrow range. So you have to resuscitate very aggressively. In pacemaker, the heart rate is fixed by the pacemaker. So it is not going to vary because of your blood loss. So that is the reason that in pacemakers, you have to be careful. Hypothermia is one more thing that the patient sometimes is brought from outside and the temperature is not maintained. The best way to maintain temperature or to monitor the temperature, they have found out that the esophageal temperature or the urinary bladder temperature. These devices not yet available in India, but this is the best way that they say to maintain that hypothermia, to maintain the normothermia. Common is beta blockers and diuretics, which will alter your monitoring in cases of hemorrhagic shock. So what we initially saw was uncomplicated shock. One is there's a progressive shock. Progressive shock is moving very fast. He is deteriorating very fast. So aggressive surgical management, you are racing against time. And there's an irreversible shock. The shock reaches to such an extent that there's coagulopathy, DIC, and hypothermia. So you have to pull back the patient from this irreversible shock back to the normal. So whatever you learned today, can you all enter into your diary? Ki whom are you going to teach it? Right? And second, what did you learn? You learned what is shock, identifying the shock, classify that shock, management of shock, and the special considerations. Okay. Thank you for your giving your most valuable effort, time, and your attention. Because this is one of the most important things that you do. Do we have a video? If you time permits, I can just play one video for you. एक पहला वाला
Hemorrhage is the most common cause of shock in trauma patients, and so the classification of hemorrhage into 4 classes based on clinical signs and symptoms is a useful tool for estimating the percentage of acute blood loss. It is also important to know that the normal adult volume of blood is approximately 7% of body weight. So, for example, a 70-kilo male has a circulating blood volume of approximately 5 liters. Here are the 4 classifications of hemorrhage for a 70-kilo male. One of the first things you'll notice on this chart is the volume and percentage of blood lost. It is pretty intuitive to see that as the classifications of hypovolemic shock increases, so does the amount and percentage of blood lost. Other key trends to notice is that as the hemorrhage worsens, urine output decreases. This is a result of hyperperfusion of the kidneys and can be used as a surrogate for hyperperfusion of your other organs. Respiratory rate tends to increase as hemorrhage worsens, likely as a compensation for the resulting lactic acidosis from the hypotension. And of course, blood pressure decreases as the bleeding continues, while heart rate increases as a reflex in order to increase cardiac output. I know this is a lot of information, but if you're crunched for time, key points to take away from this chart are that in the setting of hemorrhage, class 1 is essentially normal. In class 2, you begin to notice some tachycardia. In class 3, you start to notice hypotension along with worsening of the tachycardia. And in class 4, you get to see a worsening of all vital signs. But a good hint that you are in class 4 hemorrhage is that the patient would seem lethargic, if not completely unresponsive at this point.
Okay. Last one.
Shock is a medical emergency which can result in organ damage and death. During shock, a complex physiological response is triggered by decreased tissue perfusion. Tissue perfusion is the process of blood flowing through the body, providing oxygen and nutrients, and removing cellular waste. Ineffective tissue perfusion can result in tissue death due to hypoxia and cellular injury. There are 4 types of shock depending on underlying cause: hypovolemic, cardiogenic, obstructive, and distributive, which encompasses anaphylactic, septic, and neurogenic shock. The 4 stages of shock are initial, compensatory, progressive, and refractory. Early intervention is important to prevent progression to more severe stages. The initial stage, also called the early, non-progressive, or pre-shock stage, may be difficult to recognize due to subtle or absent symptoms. Something has led to a decrease in tissue perfusion. Cardiac output is low enough that cells begin to experience hypoxia. If tissues receive insufficient oxygen and nutrients, they switch from aerobic metabolism, which uses oxygen, to anaerobic metabolism, which does not use oxygen. Unfortunately, a byproduct of anaerobic metabolism is lactic acid. Normally, the liver deals with lactic acid, converting it to pyruvic acid and then to glucose via gluconeogenesis. But during shock, the liver is not working optimally. So lactic acid builds up in the bloodstream, dropping blood pH and causing acidosis, which causes even more damage to cells. Fissures in the carotid sinus and aortic arch sense a drop in blood pressure and stimulate the sympathetic nervous system. The sympathetic nervous system releases catecholamines, epinephrine, and norepinephrine. These catecholamines cause vasoconstriction, increased blood pressure, and increased heart rate. Less blood goes to the non-vital organs, such as the skin and gastrointestinal tract, while more blood is routed to vital ones like the heart and brain. Note that the drop in blood pressure results in decreased capillary hydrostatic pressure, the pressure blood puts on capillary walls. This triggers an increase in venous blood by shifting fluid from the interstitial compartment to the intravascular compartment. Baroreceptors also stimulate the vagus nerve, which stimulates the release of antidiuretic hormone from the posterior pituitary gland, preventing water from leaving the kidneys and thus increasing blood volume. The angiotensin system also kicks into gear. This is a hormone system that regulates fluid and electrolyte balance, blood pressure, and resistance. Vascular resistance is the resistance that must be overcome for blood to be pushed through the circulatory system and create flow. Vasoconstriction increases vascular resistance, while vasodilation decreases it. A reduction in blood flow to the kidneys triggers them to convert prorenin, found in blood, to renin. Renin is released into circulation, where it converts angiotensinogen, released by the liver, to angiotensin 1. With the help of angiotensin converting enzyme, angiotensin 1 gets converted to angiotensin 2. Angiotensin 2 is a superpowered vasoconstrictive peptide, which narrows both arteries and veins. Artery constriction increases blood pressure, while vein constriction allows more blood to return to the heart. Angiotensin II also triggers the release of aldosterone from the adrenal cortex. Aldosterone makes the kidneys retain more sodium and water and increase excretion of potassium. This means more retention of water in the bloodstream and increased blood pressure. Compensatory mechanisms increase cardiac output and blood volume, which is critical to supply vital organs. However, some compromises are being made. Perfusion is decreased to the GI tract, so it slows down. There is a risk for paralytic ileus, paralysis of the intestines. There is also decreased perfusion to the skin, which makes it cold and clammy. The one exception to this is if the person is in septic shock. In this case, there is vasodilation in the skin, and it will be hot and flush. Decreased perfusion results in parts of the lungs not getting perfusion, which means that gas exchange does not occur in these parts. This means there is a mismatch between ventilation and perfusion, and blood oxygen levels decrease. To compensate, the person hyperventilates, increasing the rate and depth of the breathing. It is important to remember that the body can only maintain rescue efforts in the form of compensatory mechanisms for a limited duration. During the progressive stage, compensatory mechanisms have failed. They are no longer able to maintain adequate tissue perfusion, which leads to worsening tissue damage. The body is now progressing towards multiple organ dysfunction syndrome. No more compensation means low cardiac output and low tissue perfusion. Cells do not receive oxygen, succumbing to cell hypoxic injury. Cells begin to swell as ion pumps fail. Capillary permeability increases, and this is key to the pathology of this stage. The barrier between intravascular and interstitial space is broken down. Fluid and protein are drawn into the interstitial space, and this results in major edema. This also depletes blood volume, the very thing the body fought to increase in the previous stage. This in turn decreases cardiac output and tissue perfusion. But what happens in various organs? When the brain does not receive adequate perfusion, there is a major mental status change. The person's speech is very slow and they will be agitated. They will not respond to stimulation. Heart cells begin to die, including those of the electrical conduction system, which tells the heart to pump blood. This results in cardiac dysrhythmias. In the lungs, acute respiratory distress syndrome develops. Increased capillary permeability in alveolar sacs, the site of gas exchange, results in their collapse, and the lungs lose elasticity. This results in fluid in the lungs, lower oxygen levels, high respiratory rate, and respiratory failure. The person requires intubation and mechanical ventilation in order to keep breathing. In the GI tract, cells also begin to die. Ulcers form as the cells that protect the gut's lining from its own acid stop working. This results in massive gastrointestinal bleeding. Because the liver cells are also dying, and the liver produces most clotting factors, clotting doesn't work well. There is also disseminated intravascular coagulation. Small clots form in vessels, further blocking blood flow to organs. These clots deplete the body's platelets and clotting factors, resulting in massive and uncontrolled bleeding. Blood oozes out of IV sites or punctures. The fourth and final stage of shock is the refractory stage. It is characterized by poor tissue perfusion, hypotension, and organ failure. Despite aggressive resuscitation efforts, the person is unlikely to survive. As a final note, the most common cause of shock in children is hypovolemic shock, while the most common cause in adults is septic shock.
So if you see, your most important thing is to detect it early, stop the bleeding.
The celiac trunk, also known as the celiac,
So replace blood, control bleeding. Okay, and teach this lecture to someone else before you sleep tonight. Thank you.
Thank you, sir, for the most engaging session. I request Dr. Ponchitra, Professor and Vice Principal, NGM New Bombay College of Nursing, to appreciate him with a certificate. We'll be breaking shortly for the lunch break. So before we move out for the lunch break, I would like to give some introduction about the workstations that will be conducted in the afternoon. So there are 4 workstations which will be handled by Dr. Deepika Sate. So she has completed her MD. She's a postgraduate teacher and guide. So she's in charge of BSc Anesthesia Technology and Operation Technology. She's also a faculty for American Heart Association. She's faculty for American College of Surgeons, accredited Advanced Trauma Life Support course. She's also faculty for Royal College of Surgeons, accredited Care of Critically Ill Surgical Patients course. So currently she's working as a professor, Department of Anesthesia, MGM Medical College Hospital, Navi Mumbai. We welcome you, ma'am. I request you to come on the stage. I request Mrs. Sanjukta Mohanty, tutor, MGM New Bombay College of Nursing, to felicitate her. Workstation 2 will be handled by Dr. Ankita Joshi and Workstation 3 by Dr. Sajid Kumar. Workstation 4 will be handled by Mr. Jignesh Vyas. Actually, I'm very happy and proud to introduce him. He's our own nurse practitioner who was passed out in 2019. So since then, he's working with us. He's a very good mentor for our nurse practitioner students. He has completed his BLS and ACLS, ATCN certified, and also certification in critical care nurse. He has also completed ATLS course. He has attended various workshops and conferences. His notable participations include India 2027 National Conference on Health and Hospital Management and participation in forensic science and its expanding horizon workshop conducted at Delhi. So Mr. Jignesh Vyas, nurse practitioner, MGM Medical College Hospital, Navi Mumbai. Welcome. Mrs. Prati Pathak, tutor, MGM New Bombay College of Nursing, to felicitate him. The workstations are arranged in the hospital